Okay. So these are the things that actually have to be taken care of. So are we live, Sharif, now?
Yes, sir, we are live now.
Okay, all right. Okay, well, good afternoon, good morning, good evening, good day. Assalamu alaikum, shalom, namaskar. All those words apply here because this is truly um, an event where people are coming together from different part of the world, from different background. And I thank you very much for joining us. Um, I with I would like to start a little formally. Mr. Chairman, Emeritus Dr. Rosenblum, President AKU, Mr. Firoz Rasool, distinguished guests, the distinguished officers of the neuro-oncological societies across the world, ladies and gentlemen. I would like to present a couple of cases that will start the discussion in this session. So if I have the permission, I would go ahead in presenting those cases. So this is a gentleman who is 63-year-old male. He had a progressive decline in mental condition over several months and had moderate right hemiparesis. He arrived from a village in the North Pakistan. He was accompanied by his son, who himself was in mid-30s. And I found out later that his son had children as well. So it looked like GBM on MRI. I had a discussion with his son, and I told him that, look, we can do the surgery, uh, we can remove a major part of this tumor, or we can do a biopsy. And after that, we will have to consider radiation and chemotherapy. And I asked him, by the way, what is your financial situation? So he said that he has some agricultural land that he sells to make a living for his family. He can sell that, and that would be about 12 lakh rupees, which would turn to be about $8,000. So I said, look, if you do all that, we can arrange for a welfare from AKU because we have a very robust welfare system. But then further treatment as an outpatient, you will end up spending all that money. And I will probably be able to, on average, give your father 9 more months of life to live. You may end up with a situation where your kids are on the street, you're under a lot of debt. So what do you think we do? Now, I didn't know the answer myself. I just had to discuss this with him. And next day, he decided to go back home, take his father home, and give him comfort care. So that was one case that, and there are a lot of cases like that, but this has sort of jolted me so much that I saved its image. The other case was of this 36-year-old male who had his initial surgery in October 2015. He also presented with weakness, myparesis, and this was actually a pretty good resection. Those who are not very familiar with the MRI, they may not understand that very well, but this was a very good resection that we had. And he improved his strength. He felt very good, no complications. He was discharged, seen in the clinic, and asked to come back in 3 months' time. Since the resection was reasonably good, we decided to hold off radiation therapy and chemotherapy at this point because it was a low-grade glioma with 1p19q code deleted. He left and did not show up in my clinic until 4 years later, almost 4 years later. And by that time, he had started to, actually, the reason he came to me was because he started to have severe symptoms of seizures. And at that time, there was a significant size of recurrence. At that time, I explained to him that, it has come back and we need to operate on this thing, and we have to consider radiation, probably, depending on what the pathology is. But then he left the clinic and never came back. So these two cases, the reason was that distance was one reason, and the financial situation was the other reason. The insurance over here is minimal, and the gross national product per capita is very low. So that brings me to this concept of global neuro-oncology, because we've been working on the global health aspect, global surgery aspect, and AKU has been at the forefront in doing things which are for the betterment of masses, instead of picking up and doing only some specialized stuff. Uh, so the circle has to be completed of global neuro-oncology. And that brought me to the idea of building up a consortium, which brought me to the idea of actually building up the Pakistan Society of Neuro-Oncology. And hence, here we are with the first annual Neuro-Oncology Symposium on the platform of PASNO. I'm really humbled. PASNO is humbled by by the support that we have received from all over the world for setting this up. We have more than 40 speakers from 13 countries. We have been endorsed by the Society of Neuro-Oncology from North America, the World Federation of Neuro-Oncology Societies, the European Association of Neuro-Oncology, the Asian Society of Neuro-Oncology, the Sub-Saharan Society of Neuro-Oncology, Sub-Saharan Africa, and then Pakistan Society of Neurosurgery, and then our own local groups of students have been very active in helping us out. And then the Brain Tumor Foundation of Pakistan, which is more patient-related, have been active in this. So this was my introduction to one ANOS and PASNO, and I am humbled and really honored by the support that we have received at PASNO. So I would, with this, I would like to invite our president, Mr. Feroz Rasool, to deliver his address. Mr. Feroz Rasool has served as the president and chief executive officer of the Aga Khan University since May 2006. Under his leadership, the university has experienced tremendous growth, improved the lives of millions of people as a leading source of education, research, and healthcare. It has helped to increase the quality of services provided by other universities and hospitals as a whole, both in Pakistan and outside, and as a role model that spreads international standards and practices, best practices, particularly during the COVID-19 pandemic. It has also assisted the governments in serving the people of Pakistan, East Africa, and Afghanistan. Under his able leadership, AKU now operates in Kenya, Tanzania, Uganda, Pakistan, Afghanistan, and UK through 6 campuses, 7 teaching hospitals, and 300 outreach medical centers. That's the largest footprint of any institution, as far as I know, in the world. And it treats more than 2 million people each year. So ladies and gentlemen, Mr. President Feroz Rasool.
Thank you very much, Professor Athar Inam. Chairman Emeritus, Dr. Mark Rosenblum, distinguished speakers, panelists, officials of neuro-oncology societies from around the world, and the leadership, faculty, and staff of the Aga Khan University, and distinguished guests. It is truly a pleasure for me to be invited and to be here on the launch of something new, but something significant. The Aga Khan University was created with a mission to bring best practices from around the world to the countries where we serve, to serve the populations that we are responsible to provide care, to provide education, to do research on diseases that affect the populations. So this particular initiative is very much consistent with our founding ethos and the vision that was set out for this institution. So although we are a small institution in terms of the number of students, we are also hopefully a high impact institution in terms of what impact we make in the countries where we are. Today we are here to inaugurate the first annual Neuro-Oncology Symposium. So this fits really well with the vision that I described. Brain tumors are one of the most lethal malignancies, especially in children, and yet they remain neglected, with very few centers in Pakistan offering diagnosis and even fewer offering treatment, and treatment not of an international standard. Treatment of brain tumor is expensive, as we've just heard from Professor Athar Inam, and requires not just highly specialized healthcare providers, but also state-of-the-art technology. And research in the treatment of brain tumors in low and middle income countries is particularly necessary as we look at a growing caseload of these types of cases. And how do we make sure that in the countries of low and middle income, Asia and Africa in particular, that we are able to provide this care. So clinicians and scientists affiliated with PASNO and with the Aga Khan University will play a role to embark on research relevant to the unique problems faced by the patients in the countries where we work. And you've heard from Athar that we are in 6 countries, and hopefully we are at the forefront of bringing international standard care through research and through education to all of these sites. So we hope to be able to do so, because I think we are in a unique position to offer advanced care for brain tumor patients, including high-end diagnostics, surgical and medical treatment, but also provide the right platform for cutting-edge research. And we've invested greatly in all of these areas, and hopefully this positions us to do what is necessary and bring us, and the partnerships that we are creating and have created to collaborate with international centers and to bring some of these centers even virtually to Pakistan to help us deal with brain tumors. And this consortium, the Pakistan Brain Tumor Consortium, and the studying of the epidemiology of brain tumors is obviously a very big part of that. The Pakistan Society for Neuro-Oncology aims to bring for the first time, a platform where clinicians, clinical researchers, and basic science researchers can join hands, and with the help of international collaborators and partners like yourselves, improve the overall care of brain tumor patients in the country, but also in the region. PASNO has taken the right step forward, bringing not just global experts for the first annual conference, but also reaching out to societies and global neuro-oncology leaders from everywhere else. So my special congratulations to the team and a special gratitude to all the speakers and participants and the panelists. And of course, my gratitude to Professor Athar Inam for taking this initiative. Thank you.
Thank you, Mr. President. One of the things that with this pandemic era Zoom is that we don't hear the sound of clappings. Although Adil is very good in setting up the clapping after each talk, but we can imagine the clappings right now. We move on next. It cannot be more pleasing to a person than to have one of his mentors. Actually, we have 2 mentors. I have 2 mentors in this session who are present here, and one of them is going to give a keynote lecture. So that's a really a situation that I feel very honored about. Dr. Rosenblum was, well, let me start like this, that Dr. Rosenblum is currently the chairman emeritus of the Department of Neurosurgery and is a professor of neurosurgery in the Henry Ford Health System, where he has expanded the department over 22 years from 4 surgeons to 32 neurosurgeons, physicians, and scientists, had responsibilities for several hospitals, developed nationally recognized research and clinical excellence. He founded and served as co-director of the Hermann Brain Tumor Center in the Henry Ford Health System Neuroscience Institute. Dr. Rosenblum founded the Michigan Spine Surgery Improvement Collaborative, a statewide quality improvement program with the Blue Cross Blue Shield of Michigan. He was one of the 4 leaders that developed a new novel patent-focused Henry Ford West Bloomfield Hospital, where he served as vice president of clinical program and director of the Center for Health Services. Dr. Rosenblum trained at UCSF from 1973 to 1979, where he helped develop their brain tumor research center. He developed the country's first brain tumor bank. I think that was probably North America's first brain tumor bank, and performed early studies on cancerous stem cells. In 1984, he founded, and for the first 7 years, he chaired the section on tumors of the American Association of Neurological Surgeons and Congress of Neurological Surgeons. He has published 7 books, 240 articles and chapters, and he has trained 63 neurosurgeons and raised about more than $45 million for neuro-oncology and neuroscience. And it has been a privilege that I was trained by him when I was in the first year of my residency. I had Dr. Gus Malik that I will introduce further later on. And then Dr. Rosenblum came in, and I saw him build things up in Henry Ford Hospital in neurosurgery, and all that imprinted on my brain. And up until now, I'm just trying to do those things that I found him do in those 9-10 years that I was there. So I will request Dr. Rosenblum to please honor us with your keynote lecture. Thank you.
Syed, I want to thank you very much, and thank you in particular for doing this to hopefully advance the care of these very important patients in this very difficult disease internationally. It's a pleasure to be asked to give this talk and to provide a historical and future perspective in brain tumor therapy. As I noted in this slide, a 50-year personal experience. 50 years, it's hard to imagine actually that period of time passing by, but it does eventually, and if we can learn something from the past, hopefully we can improve things in the future. To start off the talk, I want to mention I have no relevant conflict of interest. What am I going to talk about today? Well, I'm going to first try to give you a historical perspective to the management of diagnosis and management of brain tumors, including a vision of what it was like when I started in 1970, actually at NIH, in one of the first brain tumor clinical and research labs under Dr. Michael Walker. And then moving forward, discuss some disruptive innovations that occur, and you'll understand what I'm talking about when we talk about innovations moving later in the talk, but that occurred in the 1970s and 80s. We'll then discuss very briefly the role of surgery. There are other speakers in the past and coming up in your conference that will discuss it in greater detail, and to talk about postoperative treatments to date. Then I'll speak briefly and introduce the concept of another disruptive innovation, one that's occurring right now. And finally, a key issue to remember that we should never forget, and then conclude my talk. Well, what is the early history of malignant gliomas? Well, it was 136 years ago that Sir Rickman Godley, who, by the way, was the nephew of Sir Joseph Lister, the founder of antisepsis and the enabler of modern surgery, operated on the first patient with a malignant brain tumor where they could diagnose beforehand through his neurology colleagues where it was at the Hospital for Epilepsy and Paralysis in London. The tumor itself was extirpated partially, obviously. It turned out to be an oligodendroid glioma. What happened after that? Well, as it was stated in the press, the localization proved to be accurate and the glioma was extirpated without difficulty, but the patient died of secondary surgical complications, an infection, obviously. An outcry at once arose that the operation was unjustifiable, but the London Times published 2 sensible leading articles, and it was generally agreed that advance had been made in regard to surgical interference with the human brain. It's interesting to note, by the way, that Sir Rickman Godley's only operation on the brain was that first one. He never actually did that again. Obviously, everyone knows that through Harvey Cushing's work and many others, surgery became safer in the early 1900s. Pathology of malignant gliomas eventually was defined by Bailey and Cushing and Kernahan and others. However, early on, of course, the science was unknown and there was absolutely no effective treatment. So now I'd like you to view the diagnosis and management of this disease through the eyes that I had in 1970, 50 years ago. There was major morbidity and mortality, especially before 1950, so that many individuals were very hesitant and surgeons were hesitant to operate on these patients without understanding that the outcome might not be as good as they would like. Preoperative localization was poor. We had to rely on the neurologic examination. Can you imagine that? We're trying to teach our residents to do a neuro exam and to look in the eye at the fundus. And we would always actually look to see if there was increased pressure by looking at the fundus. I wonder how many training programs are still doing that. There was completely inadequate imaging. We relied on 3 types of imaging. The pineal gland, was it shifted? If you could actually see that on plain x-rays. Angiograms that showed abnormal vasculature, suggesting a high-grade glioma, obviously predominantly high-grade gliomas. And what was somewhat revolutionary at the time, hard to imagine, was a radionuclide brain scan, which showed us approximately where in the brain these lesions were because of the diffusion of radionuclide through the blood-brain barrier. Intraoperative localization was remarkable. We see here, and I don't know if you see my picture on the screen, but this is called an Ellsberg cannula. Charles Ellsberg in 1925, who, by the way, was the father of spinal cord surgery and the first chair of surgery at the Columbia Neurologic Institute, developed this. And this is what we used at UCSF to localize brain tumors. Hard to imagine, but what we would do, assuming that there was a tumor in a certain location, we would open up the skull in a very large fashion, open the door, the brain would be coming out at us. We weren't sure exactly where it was. So we'd incise the brain with a little corticectomy and take these needles and pass it through the brain until it tactily felt a little different. When it felt a little different, we would then open up the cortex, get to it, and obviously did a subtotal resection. The results were really quite remarkable in that, and all in the negative sense, really. Brain swelling usually ensued. We gave urea even at that time. Mannitol was starting to be used, and Decadron, which had been developed in 1961. It was so bad that some people actually questioned whether surgeries made tumors grow, if you can imagine. So this is what it was like in 1970. Post-surgical care in 1970 included whole brain radiation therapy, something we wouldn't think of doing now, except for things like primary CNS lymphomas and so on. Medical therapy was really non-existent. Chemotherapy was started by the Brain Tumor Cooperative Group using a first drug called mithromycin, which was an abject failure, but it did show that one could develop a clinical trials across the United States called the Brain Tumor Study Group. And the second drug tried was one called BCNU, which actually showed for the first time, as published in 1978 by Dr. Walker and all, and Dr. Wilson and others, that there was a very small but marginal and significant improvement in the outcome of the patients. And then a disruptive innovation occurred. And what was that disruptive innovation? I think everyone understands what I'm talking about. And it was 1971 that the MECT scan was developed by Sir Godfrey Hounsfield. You see here on the right side, the pictures that were taken, we used to actually take them just in Polaroid pictures off of a screen. But as expected, true advances are frequently met, again, with skepticism. He went to the National Neurological Hospital at Queen Square in London, which is the primary neurological hospital at that time, and explained what was going on. And they explained to him that with pneumoencephalography, I don't know if anyone's ever seen that, they're practicing today, it's a horrendous study, where one injects air into the spinal canal and looks at air in the brain. Plain tomography and angiography, there was no existing brain lesion that could not be diagnosed by imaging already. There was no obvious clinical use for a computed tomogram machine, as tomograms in general weren't really that useful, and he was sent packing. So he went to their competitor, Atkins and Morley, who had connected them with the Electronic Musical Instrument Company, who had some funds. I think they also funded the Beatles, and started then the scans, which then were named after the Electronic Musical Instrument Company, the EMI scan. In 1974, CT scan became commonly available. Surgery in the 1970s we tried to be safe as possible. Anesthesia, neuroanesthesia was just being developed at that time, but safety really followed CT imaging with improved visualization, improved lighting. The microscope gave not only magnification, but also lighting to where we needed to be. And ultrasound imaging occasionally was used to identify in real time the location of lesions and to improve the access to these lesions. Medical therapy in the 70s were developing through the cooperative groups. Tumor boards at that time, not only in brain tumors, but in the rest of the cancer field, were developing. And the only thing that we did medically was, again, to expand the use of cytotoxic agents, somewhat non-discriminate killing agents that were developed through animal testing and then humans, and included the CCNU, procarbazine, other alkylating agents. Immunotherapy was started, but really didn't have any significant effect early on. And we'll talk about how that is now a little bit. And these agents were delivered intravenously, orally, intrathecally, and intraarterially, none of which really helps very much. Radiation therapy finally was based on CT scans, so regional radiation therapy was done. That field has spent a lot of time trying to sensitize the tumor cells to radiation, and really hasn't worked very well. But one of the real advances, obviously, in our field in general, more for metastatic tumors and acoustics and so on, was the advent of radiosurgery, particularly with the gamma knife. Brachytherapy was tried, particularly as a consequence of the excellent work by Phil Guten at UCSF with temporary seeds. It seemed to have some benefit, but that really didn't last, and it's not commonly done. Then another disruptive innovation occurred along the same lines, and this was done by Paul Lauterbur. Paul, in 1971, conceived of NMR imaging, and is no surprise to you when I say that he filed a preliminary patent disclosure, but at the 12-month point arrived, he would need to spend money to file the actual patent, and he received advice from all sides that magnetic resonance imaging had no imaginable commercial use. He allowed the deadline to pass without filing, publishing it in Nature, to successfully appealing initial rejection, who thought it wouldn't really work, and it would have limited specialist interest. He obviously didn't get the patent. He did get the Nobel Prize, But the person who eventually got the patent and developed the first MRI scan was this fellow Raymond Damadian, who developed the Phonar MR scan. And in 1984, approximately 10 years ago, after CT scans became available, the MRI scan became available, and of course is the gold standard today. Now, what are the advances to the present time? Surgery, obviously, there's been stepwise improvement to low morbidity in our cases. This is tied especially to imaging, especially stereotaxis. Functional mapping is used all over in highly eloquent areas to avoid morbidity, and we'll talk about that in a minute. Radiation therapy has remained focal, despite the fact that these tumor cells frequently will invade further than the area that radiation therapy is administered. And stereotactic radiosurgery, as I mentioned, especially is useful for METs and acoustics, so much less so for the invasive primary malignant glioma. Medical therapy has been overall disappointing to date, as most people understand, with very marginal effects. So switching gears, what's the role of surgery? And again, there's many talks about this, and I'm not going to summarize it, but just to give you a perspective over the course of time, it was clearly LaCroix almost 19 years ago. It reviewed 416 cases and suggested that if you got more than 98% removal, there was some survival advantage, only measured in a little bit more than 4 months. And Sinai, 10 years later, suggested that there could be a significant median survival advantage, seen with as little as almost 80%. As everyone knows, age, Karnofsky score, and extensive resection predicted survival in that retrospectively reviewed study. More recent articles on extensive resectability included Brown 4 years ago at JAMA Oncology, showing that there was decreased mortality at 1 and 2 years with gross total resection versus subtotal resection in a large meta-analysis of 37 studies with over 4,000 unique patients in newly diagnosed glioblastoma. And that same year in Neuro-Oncology, it was suggested in a smaller study that gross total resection not only increased survival, but also yielded better quality of life in comparison to subtotal resection, confirming work that was done many years before. And we all know that if you remove the mass and don't cause a problem, patients should do better. And that's what brings me to the next concept, and that is the consequences of postoperative and perioperative complications on survival. It's a little surprising to me. Part of this work that McGurk did in about 11 years ago and published in neurosurgery about their experience of 306 consecutive glioblastoma patients with good performance status. And it was important to note that they noted that 6% of new patients got new motor deficit, which decreased their survival, median survival, over 3 months. What's surprising to me is that 5% of patients developed new language deficit, which also decreased survival 3 months. So the important thing to note from this study and others is that the results for survival, if you get a deficit, can almost completely wipe out the advantage of essentially gross total resection. And that's an important thing for us to always, of course, remember. Now, it was many years ago that Ray Sawaya at MD Anderson talked about a very simple concept, and that is looking at the various areas of the brain, including non-eloquent brain, near eloquent brain, and eloquent brain. And it's something that very simply can be looked on as shown in this diagram on the left that came from Young and Lancer's work that was published in 2011. And you can see here in the black curves, represent the expected average months of survival gained from the site of reduction, here in this case 80%. The red curve, expected average months of survival lost due to a general perioperative complication and surgically acquired neurologic deficit. And the shaded areas indicating or suggesting the net survival benefit is pretty clear here. And again, this is a generalization, okay? But if one tries to get near total resection, wanting to improve survival, it's obviously going to be better in areas where you don't cause a deficit. So it's important to remember. So in summary, the attempted gross total resection likely increases survival measured in months when it has to avoid any deficits, and it depends on tumor location. But remember, and Dr. Nam, you know this very well, and published with me on this, that all tumor cells are not in the enhancing region due to cell invasion. Whether it be before the operation or after the operation, work done by stereotactic biopsy by Pat Kelly in the 1970s, and confirmed with our neuropathologist, showed that there is still tumor cells that are invading in malignant gliomas at the time of initial diagnosis quite far away. And even in with the early neuropathologists showed or suggested that these cells actually can invade very far away from the primary site. So therefore, tumor cells are not only in the contrast enhancing area, but in the area around it, and it suggests that the flare regions reflects edema and invading tumor cells. So the question then is there a value for supramaximal resection? Lee in 2016, and with the, again, MD Anderson analysis of over 1,200 patients, suggested that improved survival would be better in approximately, if you removed approximately 50% of the flare signal, in addition to the contrast enhancement. Of course, this is a center that has much experience and focuses on not making sure that you don't cause a problem. So in summary then, there may be a value of supramaximal resection, particularly in non-eloquent regions. That's why I had talked about, or with stimulation monitoring near eloquent regions to avoid, again, causing a problem. Postoperative treatments to date include radiation therapy, chemotherapy, tumor treatment fields. Had shown in a randomized study it might have some effect, again measured in months. Immunotherapy, many of these are being developed right now, including vaccines and others, and potentially viruses have been worked on since the 1980s, both oncolytic and for gene therapy. More to come on that. But remember, all of these treatments that we're talking about in the past and in the present have potentially negative consequences. Radiation therapy, necrosis can occur clearly, particularly if you give radiation a second time. And depending upon where it is, cognitive defects can occur. I remember very clearly some, in this case, metastatic cases that had whole brain radiation therapy, or we treated in the 1970s with whole brain. Any patients that lived longer really were quite debilitated as a consequence of that. Much less now, and that's where the focus is for many radiation therapists. Chemotherapy obviously can cause systemic normal tissue toxicity. So what about the changes that are occurring right now? And I like to call that the second disruptive innovation over the course of the last 50 years, and that's occurring now. Molecular medicine, we know about this, and it's a field that is very rapidly developing and expanding. It helps us understand the development of multiple disease states, not only cancer. It allows us to try to understand disease progression, very important in the glioma field, and it's changing the concept of cancer care with hopefully minimizing the use of indiscriminate cytotoxic agents in the future. One advantage could be the possible development of cross-cancer approaches if the same molecular drivers, abnormalities are seen in other cancers, yet to see if that's happening. We call this they used to initially call it personalized medicine, but now it's called precision medicine by most people. But remember that biological issues remain. What molecular abnormality observed is important. Somatic alterations can result in tumorigenesis, either by genetic or epigenetic changes in the genome. What in general is most important? What should be our targets? Then, of course, there's tumor heterogeneity in space and in time. And we'll get to that in a second. Tumor stem cells, are they the key target? The majority of cells in the tumor are not stem cells that have the capacity to continuously grow forever. But are they necessarily the key target to get to? What about the invading tumor cell? We could remove all of these tumors completely and cure them if the tumor was not invading. A low grade, sometimes a low grade glioma has a possibility of a very long term survival. If there was no invading tumor cells, meningiomas and others, for example. Well, are those invading tumor cells the same cells? Are they the stem cells? So do they have just altered capability of migrating rather than proliferating? And what causes them to sit down in another site and start another tumor up again? Resistance development, it's inevitable. Just like an infectious disease, it's inevitable that resistance will develop. And there's also, obviously, as I mentioned before, normal tissue toxicity, both systemic and brain. If we're going to administer something in the brain or get something into the brain, what's its effect on the neurologic system and other normal tissues there? We have to also remember that the normal intracellular pathways are complex and are interrelated. And that cells can often adapt to a block in a pathway. For example, here's a slide that was given to me by Tom Mickelson from one of his colleagues. Following the treatment with Avastin, a VEGF inhibitor that when we first gave to patients, it was remarkable. We thought now we finally have the silver bullet because all of these patients' tumors seemed to disappear. Well, the enhancement disappeared. But eventually, these tumor cells that eventually, or the tumors that we saw eventually shrunk along with the blood vessels. But over time, there are a variety of different means. I'm not going to go into detail here, but that these adaptive evasion occurred. And we know that VEGF inhibitors and Avastin is not the cure-all. It just changed things. Sometimes it actually made these tumors invade throughout the brain when they finally recurred. So tumor cells likely have alternative pathways around blocked genes in their products. And what does that mean? That means because it would be not reasonable to assume that we're going to have a silver bullet cure of brain tumors. And for years, I stopped talking about a cure. A more realistic goal is to try to make glioblastomas a chronic disease by treating them with a cocktail of multiple molecularly target agents, kind of like what happened for the care of AIDS patients. When I was growing up as a resident and as a young faculty in San Francisco, the AIDS epidemic occurred. Another interesting experience in my 50 years. And at one point in time, I was the one that operated on every single AIDS patient in San Francisco, the San Francisco Bay Area for about 5 years. Didn't make my wife very happy. But most of it was really just stereotactic biopsies. Well, I got to tell you, when we first saw this happening, this was, as they described, the gay disease at first, and then all of a sudden, these unusual infections occurred, and the average patient lived less than a year, with perhaps maybe some of the tumors patients living a little bit longer. But that changed with the advent of anti-HIV drugs, particularly with the advent of cocktails of 3 or more of them, lowering the chance for resistance to treatment. So as seen on this slide, the total life expectancy of HIV-infected 20-year-olds in 1996, not that long ago, was 39 years. A little more than almost 15 years later, it became almost normal, 70 years. In the United States, the average survival of a man is 76 years old, for example. HIV deaths due to AIDS was 78% in around 1990, and that decreased to 15%. So the point is that one can use a combination of agents, which is initially we should be thinking of using. Eventually, problems with pharmaceutical industry and so on makes that a little hard right now, but it still should be our goal. Now, what about the treatment of recurrence? We all talk about, oh, we've got a recurrence. Well, sometimes we need to actually confirm it. Let me just show you an example of a patient I operated on in 1994. This young man has a 36-year-old with seizures, performed a gross total resection of his right temporal tumor. And obviously, this is one of the best things that we could think of doing. But it was an anaplastic astrocytoma, or a grade 3. I just gave 54 gray and PCV chemotherapy. 1 year later, everything was normal. And 2 years later, all of a sudden, the person was developing some weakness in the left arm. FDG PET was positive, suggesting recurrence. And for some reason, I reoperated on him, and it turns out there was pure radiation necrosis, only with 54 gray. It's amazing. Pure radiation therapy. Well, here he is, 26 years later, alive and well, with some deficits, some cognitive deficits, a consequence probably of the radiation at least. But this was not a recurrent tumor. If you were just simply to treat this patient as a recurrent tumor, whatever your treatment was would be considered quite efficacious, wouldn't it? So we really should think about making sure as best you can that you do have a recurrent tumor. Which brings me to the point of what happens from the primary tumor at diagnosis to recurrence. And we should give credit to the GLASS International Consortium that has clearly described something that was thought of very early in the development of stem cells, the clonal development and then progression, that at recurrence, these tumors could look somewhat different. And they have just a couple of months ago, published in Nature a study titled Longitudinal Molecular Trajectories of Diffuse Gliomas in Adults, where they clearly, nicely show mutation burden increase at recurrence in 70% and penetrated most of the tumor. There was a acquired hypermutation in aneuploidy. The hypermutation is sometimes secondary to our Temodar therapy, as well as other treatments or spontaneous changes. And subclonal selection was associated with more aggressive tumor behavior and decreased survival. So that brings us to the question of, do we need to resample locally recurrent tumors? Some studies had suggested in 2015 and 16 that might be the case. But I point out this article that just came out in Journal of Clinical Oncology a couple of months ago again, which seems to answer, at least in my mind, that question. Then that an article titled Molecular Evolution of IDH Wild-Type Glioblastomas. Notice that we're now really in the molecular era. Affects survival and design of precision medicine trials. They showed that there are changes in mutations status for all genes, and some of them might be therapeutic targets. EGFR V3 was lost in 37%. MGMT changed 23%, a quarter of the patients. So in summary, a druggable target at first presentation may no longer be present in the recurrent tumor, and a repeat biopsy should be considered before inclusion into targeted therapy trials. It's of note that anyone developing trials should understand also that means that molecular changes can affect target trial size and design. So, and I think most advanced trials understand that, and more patients need to be accrued unless you biopsy these patients at recurrence. To add to the precision medicine suggestion, rebiopsy for diagnosis and molecular analysis, I believe, should be considered. Could we use surrogate analysis like CSF and blood? And there's no answer here yet. A lot of labs are working on that. Can you just take blood? The CSF analysis may not be as relevant because of it's still an intervention. Can you see the circulating tumor cells, circulating tumor DNA? Can you look at exosomes? What about epigenetic alterations? These are all interesting things and some deserve further study. Nevertheless, and even after you identify these molecular targets, you need to decide whether or not it's going to work. Therapeutic agent selection continues to need relevant preclinical models, and we should confirm in vivo activity in man. The neurosurgeon will play the very major role in that. It suggests that it was suggested early on in my career that chemotherapy would cure every brain tumor, but the problem was you couldn't get it in. Well, obviously that changed to, well, you need more different types of agents, and now we're back again. If you have potentially effective agents, will you be able to get in? Brain delivery will remain an issue. CED and a variety of other methods to doing it, encapsulated endosomes maybe can help us on that, but brain delivery still is the bane to our therapeutic existence and trials. We're likely to need therapeutic cocktails, and industry and government foundation support will remain critical. Excuse me. So let me switch gears to something near and dear to my heart. And that is something as a surgeon we need to understand, because we're also physicians. Yet we need to see the disease through the patient's eyes. These are not the laboratory studies that we do. These are clinical studies, and the patient is our target. We need to remember what they see. When you make a diagnosis of a brain tumor, brain cancer, this is how they feel. Are you kidding me? And that leads to shock, a loss of hope, and crisis. And anyone who's on the front lines and seeing these patients, when you first make that diagnosis, you're the most important person at that time in those patients' lives. And one bad word, one misconstrued comment about fatality, about deficits, and so on, can really change the patient's quality of life as well as their family's quality of life. What do patients desire along the treatment continuum? They desire us to be honest and compassionate. They desire us to tailor information and take more time communicating. Does everyone have a lot of time? But we should spend the time. We should include their family. We should support patients through the expected emotional crises which occur at the time of diagnosis, but also at recurrence. But also, you have to remember, at every single time they get an imaging study to determine whether or not the tumor has come back, and that anyone who has cancer understands that in general, brain tumors in particular. And we should be highlighting the positives and providing hope when that's real. Well, to that extent, how can we help to do that? Personally, of course, but also in participating in tumor boards that assures a standard of care, and occasionally when clinical trials are available, making that available to the patient. And in particular, if one has the opportunity to develop comprehensive brain tumor programs that follow the patients through the disease site, and provides the best patient and family support system, aside from providing opportunities for research and advanced clinical trials. And here's just an example of a diagram of what we were lucky enough to develop, the Hermelin Brain Tumor Center at Henry Ford, named after a philanthropic fellow who David Hermelin, who had a tumor and his friends donated to start this. Importance of philanthropy. And with these patients following, not only at diagnosis, with the multiple individuals that come in and participate all the way through their eventual, I hesitate to say cure, but cure, or all the way until to the end of these patients' lives. Very important. Who's important in this? Well, the neuro-oncologist is the most important person to this process, coordinated care. And the tumor board is key, obviously, as long as you meet on a regular basis, provide information in a timely and relevant fashion. We all think that we are, as surgeons, the most important person in that patient's life. We are for a very short period of time. The real person or people that are most important, believe it or not, to the patient and their family are the nurse navigators or the nurses. So I'd strongly suggest that anyone trying to develop these comprehensive centers spend a lot of time finding and nurturing their nurses, who would be the person to answer questions and help these patients and their families along their continuity of care, along the entire system timeline that they have this disease. It also permits patient-centered improvements that improve their quality of life. In conclusion, What's the role of a neurosurgeon and what are our responsibilities? Well, the role of a neurosurgeon early in my career, and particularly after the advent of CT scanning from 1974 to the present time, has been to obtain a tissue diagnosis, no surprise, and remove as much tumor as safely possible. And as I've described, and everyone knows, that has been more possible as time has gone on. And to play a role in tumor boards, it's just not a time to sit down and give your thoughts about what it'll look like at the time of the surgery. What's the role of the neurosurgeon now? And hope I've suggested to you that it should be more than that. We should obtain tissue for molecularly directed precision therapeutics. This means not just tossing something to the pathologist, in my mind, but making sure that you can save this tissue if you can, particularly in the academic centers. Play an increasing role in tumor programs, and consider safely obtaining tissue at recurrence for new therapeutic selection, because things could change if, in fact, you're giving molecular therapeutics. What are our responsibilities? Our responsibilities should be to understand and help lead efforts to make glioblastomas a chronic disease. I think we do have that capability. To contribute to science, develop new approaches, and encourage clinical trials, and embrace innovation, especially disruptive ones, but even stepwise ones. Disruptive ones occur very, very rarely. In my career, it's just two, in my mind. But these things, these changes are frequently met with skepticism, as I've mentioned. It always happens. Keep your mind open. You never know what the future is going to hold. Our responsibilities include apply optimum judgment, skill, and technology. We're trained for it, and we continuously learn, and I've continuously learned over 50 years, as most of you have. To technically attain maximum tumor resection without causing deficits. I have to emphasize that, as I've mentioned to you, and obtain representative tissue for modern diagnosis and enable those molecularly directed therapeutics that we've talked about. Why? Because the future is on our hands. Why? Because it's important. And why? Because the future can be bright. Now, in your hands, those of you who are listening in on this wonderful session, and those of you who participate in the nationals and international efforts to understand these tumors better and to develop better treatments. Thank you.
Thank you very much, Dr. Rosenblum. It just brought back my memories of what I learned from my mentors. It was not only about cutting, it was about the whole fullness of being a surgeon, being a doctor, being a physician, being a human being. So it was a refresher course for me, at least I can say. This is what I was trained by you guys. Thank you very much. I was overwhelmed by the responses that I received, and there were quite a few great neuro-oncologists, neurosurgeons who couldn't join in, but they sent me the messages. So I'm going to run some messages that will be in two portions. So it's going to start here first. This is for 5 minutes, and the other one is going to be for 5 minutes too. So there we go.
Hi, my name is Ryo Nishikawa. I'm the president of the Asian Society for Neuro-Oncology. I congratulate Pakistan Society for Neuro-Oncology on its inauguration and wish a great success in improving and the treatment and care for brain tumor patients and relevant research in Pakistan. We welcome you to the Asian Society for Neuro-Oncology. Congratulations again to you all. Thank you.
Hi, my name is Mart van der Wens. I'm currently the president of EANO, the European Association of Neuro-Oncology. I'm very happy to see that Pakistan has developed its own neurological society, which will be for the benefit of brain tumor patients. And I therefore wish your society and Adher Eden very much success on their first meeting. And I look forward to collaborating with your society.
Good afternoon, Pakistan's NO members, friends and colleagues. On behalf of the World Federation of Neuro-Oncology Societies, I'd like to congratulate you on the inauguration of the Pakistan Society of Neuro-Oncology and first annual Neuro-Oncology Symposium. As you know, the WFNOS was established in 2012 with the goal of providing an international platform for education and research in the field of neuro-oncology through interorganizational collaboration between SNO, ASNO, and EANO charter societies. I'd like to invite Pakistan SNO to join WFNOS. WFNOS has been holding quadrennial meetings since 2001, and the 6th WFNOS meeting was scheduled to be held in May 2021 in Seoul, Korea. But due to COVID-19 pandemic, now rescheduled to March 2022. I hope our Pakistan SNO members actively participate in the meeting and enjoy the exciting scientific and social programs. Thank you.
Good morning, everybody. I know that the Pakistan Society of Neuro-Oncology is hosting the first annual Neuro-Oncology Symposium in collaboration with the Aga Khan University. On behalf of International Stereotactic Radiosurgery Society Board, I wish you success for this important, great initiative. Especially in the current scenario of pandemic, the collaboration among different disciplines becomes strategic in facing the complexity of neurological tumors. The faculty and the scientific committee of your society have provided a robust program in this direction. So, good job. And I hope to see most of you attending the biannual IRS Congress in Brisbane in 2022. Arrivederci.
Hello, everyone. I'm Hootie Warren, and I'm from the Fred Hutchinson Cancer Research Center in Seattle, Washington. And it gives me great pleasure to congratulate the Pakistan Society for Neuro-Oncology on its inauguration, and in particular to congratulate the individual whose energy, dedication, and passion really led to the inauguration of this society, namely Dr. Arthur Ina. And I want to wish the society all the success in the world in its efforts to promote better care for brain tumor patients in Pakistan and to support great research into better treatment and prevention for brain tumors all over the world.
Hello, everyone. My name is Stephen Kalkanis. I'm the president of the Congress of Neurological Surgeons, and I bring you greetings from Detroit, Michigan, from Henry Ford Health System in the United States. I so wish that I could be there in person to express my support and my profound and heartfelt congratulations on the occasion of the first ever Neuro-Oncology Symposium held by the Pakistan Society of Neuro-Oncology. I want to congratulate Dr. Inam and the entire group for putting together a phenomenal program. I look forward to accomplishments in the years to come and collaboration between the Pakistan Society and the Congress of Neurological Surgeons and with neurosurgeons all over the world. Thank you for your leadership. I wish you great success, and I'm very excited for the future as we work together on the dreaded disease of brain tumors and how we can improve outcomes for our patients in Pakistan and around the world. Thank you and congratulations.
So thanks to all of them. I'm going to write a note and maybe send them the video also. Okay, so next we are going to ask another great friend of PASNO. I mean, all these people have provided me so much support over the last couple of years. I'm really tremendously indebted to them. So Isabel Germano is a professor of neurosurgery, neurology and oncology in the Khan School of Medicine and director of the Mount Sinai Comprehensive Brain Tumor Program and the co-director of the radiosurgery program. He has worked in the field of image-guided brain and spine surgery, developing new technology for several years. Dr. Germano's expertise includes brain tumors, computer-assisted image-guided neurosurgery, epilepsy surgery, and radiosurgery. is one of the pioneers of computer-assisted image-guided neurosurgery. Romano has chosen to give the Charles A. Ellsworth Lecture, the first woman to receive this honor since the lecture establishment 67 years ago. Active in national neurosurgery organizations, Romano has served as an executive committee member of the Congress of Neurosurgery, as a member of the board of directors of the AANS, as an executive committee member of AANS CNS Joint Section on Tumors, and as a scientific program member for the AANS CNS and American Epilepsy Society. In 2000, she was awarded as one of the best doctors in the Hall of Fame magazine. She has authored 3 books and over 60 research publications. It's just amazing how she did all that. Isabel, off to you.
Thank you very much for having me today. This is really an exciting day, and I start by congratulating the society, congratulating the presidents, and Professor Enam, congratulating you for putting all this effort into the first annual Neuro-Oncology Symposium. And clearly, we're looking forward to collaborating with you over the years. Today, I was asked to represent 2 great organizations. One is the WFNS, where I serve as the chair for the Education and Training Committee, and 2 is the AANS CNS Joint Section on Tumor, where I am one of 2 officers, and I serve as Secretary Treasurer. I would like to focus a little bit on a mission that I think is established by both organizations, the WFNS and the Joint Section of Tumor, and that mission is education. And I think that over the years, serving as the chair for education for the WFNS, we provided this mission statement that I think is quite important, because not only we want to educate people at home, but we want to create a community that is over the world, that is everywhere in the world. And so the word education brings means to bring out, to develop from within. And this is a process that allows us to facilitate learning. And the learning is facilitated by acquiring new knowledge, by developing new skills. And for us neurosurgeons, the development of new skills is very important. And also to establish new values. And how do we go by doing that? We do that by training. And for all of us that have been athletes before, we know how important training is. And for surgeon, training is as important as for athletes. We do that by meaning of discussion, and this is what these symposia are all about. And we do this also by storytelling, by sitting next to our professors and hearing what they went through. And by the way, Professor Rosenblum, your lecture was exceedingly inspiring, beautiful, was not storytelling, was facts, but still you brought us some incredible small facts that some of us might have not known just because we were not there at the time. So thank you, Professor Rosenblum. And we need to remember that the education goes into learning stages. And why do I say that this is important? I say that this is important because for neuro-oncology, it's very important that we develop a way to educate our trainees as we move along. And clearly a medical student needs an education that is different from when we train a fellow. And in the first few years of practice, that individual thinks that he or she knows it all. And then finally, when we become professor, this is when we really understand the meaning of disruption and the importance of having to change it all, to relearn it all over again. So we are constantly learning. And so I believe that similar to sports, where it takes a team to score that goal, for us, passionate about brain tumors, it really takes the entire work community to get together and to play with each other and to make sure that we keep in mind, just like Dr. Rosenblum eloquently said, that we're here to serve our patients. And the only victory, the only goal that is present is that of improving the outcome of our patients. And how do we do that? I think that we do that by working together, by understanding that today in 2020, there are still differences in between countries. And so that although we create some guidelines, that those guidelines might not be guidelines that are appropriate for across the world, and that we start to work at seeing what is present and what we can develop, and what are the guidelines like in those places that are building a program. And I hope that we can do this together, not just today in these 2 days of meetings, but over the years. And I'm really looking forward to collaborate with the Pakistan Neuro-Oncology Society. Thank you very much.
Thank you, Isabel. Thank you for your kind words, and thank you for reinforcing what we learned from Dr. Rosenblum. So next we have Chas Haynes. So I never physically met Chas, actually, but then the way he responded on emails when he learned a couple of years ago about PASNO, I felt like I know him for years. That's the warmth that I found in the email. And I hope when I meet you personally, Chas, I will see the same warmth in you. Chas Haynes, JD, is the Executive Director of the Society of Neuro-Oncology, a position he has held since 2006. Mr. Haynes is responsible for the day-to-day operations of SNO and works with the elected leadership to implement the Society's strategic plan. He has over 25 years of experience in the leadership and operational management of non-profit medical associations, including the Collaborative Ependymoma Research Network, the International Brain Injury Association, and the North American Brain Injury Society. Throughout his career, his primary focus has been in the area of neuro-oncology and acquired neurotrauma. He holds a Juris Doctor degree from the South Texas College of Law. So thank you, Chas, for all that you have given me. And please say a few words that we would keep to ourselves.
Thank you so much, Dr. Adam. And I too look forward to the time where we can all travel again and be together. So we very much look forward to that, hopefully sooner rather than later. So I'd first like to thank and congratulate the organizers of this inaugural event, and of course the founders as well of PASNO, including Dr. Adam, for their hard work. I know that the 3,000 members of the Society for Neuro-Oncology welcome the active participation of PASNO in the global community of neuro-oncology societies. So I'm going to talk briefly today about building international neuro-oncology societies and how we are stronger working together as a group. But again, I would of course like to congratulate PASNO, and we look forward to many years of productive collaboration. So I did want to start though with a slide that I saw just a couple of weeks ago when I was participating and watching the Society for Neuro-Oncology in Sub-Saharan Africa virtual conference. And Dr. Patrick Banka, a neurosurgeon from Ghana, showed this slide in his presentation, and I was touched, and I just found it so appropriate to the current field of neuro-oncology that I wanted to share it all with you today as we look to collaborate globally across borders. So to begin, I thought it might be interesting to take a look at some of the multinational and regional neuro-oncology societies as they exist in the world and provide a little bit of background and history on the evolution of neuro-oncology societies over the last few decades. The first multinational and regional neuro-oncology society was established by our European colleagues in 1994. That was followed 1 year later by the Society for Neuro-Oncology, the society that I now represent, by Victor Levin, who was then the the chair of MD Anderson Cancer Center in Houston, Texas. A little later on, the Asian Society was established in 2002, and of course that's the home society for PASNO. More recently, we've seen a multinational organization established in Latin America, SNOLA, Society for Neuro-Oncology Latin America, in 2016. And a couple of years ago, the Society for Neuro-Oncology in Sub-Saharan Africa was established. In addition to the regional and multinational societies, over the years, there have been national societies that have grown and evolved and developed all over the world. And as a result, it occurred to us that there was a need to at least, first and foremost, just to find out who these organizations were and who their leadership comprised of, and make sure that we had relevant contact information, just provide a platform, nothing else, that we could at least communicate with one another. So in 2012, the World Federation of Neuro-Oncology Societies was founded, with Michael Weller Avellano serving as its first president. The WFNOS essentially has 5 goals. First, just to codify the relationship of national and regional neuro-oncology societies and make sure that we have contact information for our colleagues around the world. To foster professional exchange and improve communication among those societies. Perhaps the most important goal of the WFNOS is to organize and to help plan the quadrennial WFNOS meeting, and I'll speak about that a little bit later on, a couple of slides. The coordination of international fellowships and scholarships and other outreach initiatives, and to explore collaborative publications and education. The charter states of the WFNOS are the Asian Society, the European Association, and the Society for Neuro-Oncology in North America. In addition to the charter states, there are the member states, shown here, that now include Pakistan. There are other societies that have yet to apply for membership in the WFNOS, so suffice it to say this list is probably a little bit longer, and it's fairly fluid. But it's very nice to see all of these organizations coming together and organizing around one platform. So as I mentioned, the quadrennial meeting of the WFNOS is a key component of the effort of the Federation. It's held on a rotating basis between the charter states, so the United States, Europe, Asia. The next opportunity for the meeting was the Asian Society to host the meeting. It was originally scheduled for May of next year, but due to the pandemic, that event has been moved. But I would encourage all of the members of PASNO and everyone indeed around the world who's involved in neuro-oncology to save the date for March 24th, 27th, 2022 in Seoul. So I'd like to turn to some of the efforts of the Society for Neuro-Oncology in North America that may be relevant to the members of PASNO. We have an international outreach committee. It's led by James Balogun, Zarni Elwin, and Edja Ndoum. James and Zarni will actually be speaking at this conference later today. But as the leaders of that committee, they're tasked with developing outreach sessions at SNO's annual meeting. They're also launching an international mentorship program, working on special issues of our journal on international outreach issues. And one very successful initiative of the International Outreach Committee is to solicit applications for travel scholarships to the SNO annual meeting. That initiative has been quite successful. There are many, many more applications than we can accommodate every year, but we've been thrilled to bring young investigators from all of these countries to the SNO meeting, sometimes several from each country. So that's been extremely successful and something we look forward to continuing as soon as the pandemic is, of course, behind us. Another effort of the International Outreach Committee is to organize a course that we do, would do in a lower middle income country. And so it's sort of the opposite of the travel scholarship to SNO. We sort of bring SNO and other international experts to the LMIC. And to date, we've organized courses in Malaysia and Morocco and Sri Lanka and Peru, Nigeria and South Africa, and next year, hopefully in Ghana. So I think it's an opportunity that we would welcome discussion with the PASNO leadership to explore what a Wilkins-Barrett course might look like in the future in Pakistan. We publish a number of journals. Some are published in collaboration with our European colleagues, but sometimes these journals, especially our subscription-based publications, are quite expensive. So through our publisher, Oxford University Press in the United Kingdom, we participate in several initiatives underwritten by the World Health Organization to make sure that not just our journals, but indeed all relevant medical and academic journals are available in developing regions at reduced cost, or in some cases, no cost at all. Certainly all 144 Oxford University Press journals are available through these efforts. After the meeting, if anybody is interested, if your academic institution or library is not receiving these, I can certainly point you in the right direction at OUP to make sure you can make an application to get them. So at SNO, as I mentioned, we published 3 journals. Neuro-Oncology is our flagship publication. I think the entire field, not just SNO, but the entire field of neuro-oncology can be very proud really, in the top 10 oncology journals in the world, entire, oncology journals in the world. I think the top 15 neurology journals. So I think as a field, we can be very, very proud that we have a flagship publication that truly is an outstanding journal. We did recognize that a lot of the content in neuro-oncology can be quite esoteric, and perhaps there was a need for more practical and applied content that wasn't able to make it into the neuro-oncology, and so we launched a few years ago, about 6 years ago, Neuro-Oncology Practice, which really sort of had the applied content for frontline clinicians. And that journal has been quite successful and is now published 6 times a year and is fairly searchable on PubMed. And Suzanne Chang is the editor of that publication, and she will turn that over to Martin Taphorn in Europe at the end of the year. Our most recent journal, launched last year, is Neuro-Oncology Advances, and is edited by our current president, Dr. Galerizadeh. She had the foresight to speak to OUP about some really significant changes in the publishing field that are rapidly occurring. And our relationship with Oxford has been really quite excellent, and they were very receptive to the idea of launching a new type of publication that was not subscription driven, but indeed accessible to anybody with a web browser. Truly, this is the way that medical and academic publishing is going. I don't anticipate too many more subscription-based journals to be launched. The open access model is quite different, but it certainly allows for a much more effective and broader dissemination of knowledge through an open access publication. So we're thrilled to have that title available. And of course, as I said, anybody with a browser can access that content. Like PASNO, we had hoped to have an annual meeting in person. We had hoped to be in Austin, Texas to celebrate our 25th anniversary. Unfortunately, due to the pandemic, we had to make the difficult decision not to hold the meeting. However, we will be organizing or actively planning a virtual event that will occur roughly over the days of the conference, a little bit shorter. For the first time, we are offering an international outreach rate to the conference, and so we're hoping that we'll be able to attract more international colleagues to our meeting. And indeed, moving forward, we're looking to incorporate international outreach rates into everything that we do. So whether it's a registration for the annual conference, access to the journals or other educational initiatives, access to our boutique meetings. We've now started organizing meetings on brain mets, pediatric neuro-oncology, meningioma, basic science. Next year we have a standalone conference on just on clinical trials. And across the board, there will be a reduced rate for lower and middle income countries. So we're committed, I think, to working with PASNO. We're thrilled, again, to have PASNO join the international community of neuro-oncology societies. We look forward to working with Dr. Anam and the leadership of PASNO in the future, and hopefully seeing all one another next year in person, either in Boston, where SNO will have its annual meeting, or in Pakistan. So thank you very much.
Thank you very much, Chas, for all this enlightenment. I did not know a lot of these things that you went over. A lot to think about. Thank you, really. So I just had another clip that I'm going to show you, and let me share that video. Okay, here we go.
Dear colleagues, dear friends, my name is Eric Bouffet and I'm a pediatric neuro-oncologist in Toronto. I have a great connection with your country and we have an amazing twinning program going on between our institution in Toronto and several institutions in Pakistan. I want to take this opportunity to congratulate you for the inauguration of your Pakistani Society of Neuro-Oncology. And I want to wish you great success and long life. I'm happy to collaborate with you. It's a privilege and an honor, and I thank you for this.
Assalamu alaikum. As president of the Pakistan Society of Neurosurgeons, I'm pleased to be here today at the first annual Neuro-Oncology Symposium. I'm honored to be invited to speak at this meeting. In today's world of ever-changing oncology treatment and trends, new researches are coming out every day. We as neurosurgeons have to be involved and be a part of this. I look forward to more of these collaborations between Pakistan Society of Neurosurgeons and the Neuro-Oncology fraternity. Thank you.
Good afternoon. I'd like to congratulate the Pakistan Society for Neuro-Oncology in its inauguration and by improving patient care for brain tumor patients and the research associated. This is Tom Mickelson from the Hermelin Brain Tumor Center at Henry Ford Hospital in Detroit. All the best for a good meeting.
Good morning from London. I was so pleased to hear that my colleagues in Karachi have set up the Pakistan Society for Neuro-Oncology. We all know that brain tumors are rather orphan diseases, and I think it's splendid that people in Pakistan now are going to be able to benefit from an organized society to improve care of patients with brain tumors in Pakistan. I send my congratulations and best wishes, and I'm sorry I'll not be able to join you for the meeting in early September.
Good afternoon. I appreciate the invitation by the meeting organizers to actually present at this first annual Pakistan Society of Neuro-Oncology. I've actually had the privilege of knowing Dr. Inam for over the last 20 years, as he was a resident at Henry Ford Hospital many years ago. And all of us at Henry Ford have really been honored to follow his career through the years. The establishment of the new Pakistan Society for Neuro-Oncology is truly a remarkable achievement. And we all would like to congratulate Dr. Inam, the Society's founders, and the future members on their commitment to neuro-oncology.
Hello, I'm Jim Osman from
I'm happy to be invited to talk to you at this meeting. I want to thank Asher for the invitation. Wish you all the best of luck in having what is a good meeting. I'd like to take a minute or two of your time to tell you some history you may not know about Pakistani neurosurgery. When I went to Henry Ford Hospital as chairman in the 1980s, Gauss Malik, who's on your program, introduced me to neurosurgeons in Pakistan, in particular Bashir Ahmad, who is one of the leaders and founders of Pakistani neurosurgery. With that, many of the neurosurgeons from Pakistan and around the world, we had about 400 of them, came to train with us in Detroit and Chicago. And almost all of them returned to their countries to serve their countries. Over 2/3 of them assumed leadership positions in their various countries and organizations. Arthur went to Henry Ford Hospital after I left, was trained by Mark Rosenblum, who's also on your program, and Gauss, and has some advanced degrees, molecular medicine, has done an outstanding job as a member of our journal editorial board, and he's put together this meeting of international consultants in neurosurgery. About 25 years ago, during that time, we developed the first international meeting in Pakistan. And now here you are, 25 years later, with a very advanced meeting using advanced technology. You probably know along the way we developed a journal after our travels around the world, trying to answer the needs of people, neurosurgeons around the world. They wanted free information on all aspects of neurosurgery. We founded Surgical Neurology International. It's an internet-only journal. You can access it on the internet. It's free. All of its content is free to everybody. It has scientific papers, videos, lectures, theses, all kinds of information a neurosurgeon will want to know. This is the path to the future. What you're doing is the way to the future. By 2050, if you look at where Pakistan will be, you've already advanced in the 25 years I've known, and in another 30 years, 25 or 30 years, you will be even more advanced and you can help the people of Pakistan further and people around the world. So we wish you a lot of luck. We enjoy being in Pakistan. Sorry we can't be there now. And I really appreciate the time to be with you today.
So thank you very much for listening to that. And I have to thank all those who sent the messages. So moving on, as I mentioned earlier, this is really an opportunity for me to feel proud, to feel happy, to feel good that my mentors are here, and I can introduce them and I can listen to their word of wisdom, and let other people hear the same what I learned from them. So Dr. Gauss Malik is going to tell us a few things next. Dr. Gauss Malik graduated from King Edward Medical College in Lahore in Pakistan in 1970. In 1970, he began his general surgery residency in Henry Ford Hospital. So you might have noticed that this whole theme that we have in one annos, it's a little more heavy towards North America. And in North America, it's a little more heavy towards Henry Ford Hospital. Maybe that's the way it is because Henry Ford Hospital was and has been doing things all along for neuro-oncology. And we have trainees from Henry Ford Hospital who are oncologists in Pakistan, quite a few of them. So Dr. Malik started his residency in Henry Ford Hospital in Detroit, Michigan. Then he did his neurosurgery residency same place, and that's when Dr. Knighton was actually his mentor, another giant figure in neurosurgery. He then joined the Henry Ford Medical Group of Neurosurgery staff in 1975, and then was certified in neurosurgery in 1978. Dr. Malik had a series of outstanding accomplishments at the Henry Ford Health System, where he was appointed Chief of the Division of Neurosurgery at Beaumont Hospital and maintained his position as Vice Chief of Neurosurgery at Henry Ford Hospital. He has received numerous awards of for his active service and involvement in the community that he represents in Michigan area. And he has trained more than 70 neurosurgeons currently practicing across the world. So this little paragraph really doesn't say much. And whatever I say about Dr. Malik or whatever I said about Dr. Rosenblum, it does not reflect the amount, the intensity, the gravitas that these people had. You really have to spend a few days with them to understand how great these people are. It has been an honor for me that I was trained by them. So, Dr. Malik, we are going to move towards some question and answer because this session is more of an interview with you. Now, we know that you actually came from Pakistan and you have been in touch with Pakistan all along. You have been traveling back and forth, doing cases over here, teaching residents, trainees, young faculty. And we know that there is all these neuro-oncology societies across the world and all these big societies also. So what is your thought? What is your wisdom about that? Why do we need to have this local society of PASNO, Pakistan Society of Neuro-Oncology? And if it is worth it, then what should be our direction in moving the society forward?
Thank you very much for the invitation, and obviously it is a double pleasure and honor to be included in the program. As we heard from multiple leaders of different neuro-oncology societies and neurosurgical organizations, there has to be an organized way of any progress that you want to make. If you just look at brain tumor program, Mark Rosenblum took the initiative and started the tumor section of AANS and CNS. And that has gone on to Neuro-Oncology Society and then international societies. Same is true at our place at Henry Ford, having initiated the Urban Brain Tumor Center, bringing different specialties together and providing an organized system of care of those patients, education as well as the research. Pakistan has over 200 million population, obviously scattered over a large area. I'm sure that in many centers, there is excellent work being done, but without being coordinated, it's difficult to have the progress. Dr. Hausman reminded me the first organized meeting that we had in collaboration with Pakistan Society of Neurosurgery. It was actually initiated, the society was initiated and registered in 1987 while we were in Spain with Professor Bashir Ahmed and Iftikhar Raja. But we managed to do a Henry Ford Health System actually did a special program of frontiers and controversies in neurosurgery in Lahore in 1989 and had other lectures in Islamabad in addition to it. But World Federation of Neurosurgical Societies was kind enough to actually grant us an educational seminar. This was the second educational seminar after Argentina that was held in Pakistan. We had close to about 120 participants from adjacent countries. And that helped us initiate additional educational systems. So back to your question, without an organization, which is hard to develop, it's difficult to bring people together, but without an organizational structure, you cannot make a progress.
Thank you, Dr. Malik. Any advice? I've spent my life based on your advices. Any advice about PASNO that you would suggest? I know there is a lot of different barriers, barricades in Pakistan, which probably you know better than most of the people who are on this Zoom link. And then the bigger audience is actually on our Ustream. But what's your advice that that PASNO should do to make sure?
I think it's very critical to a process of inclusion. You know, as one slide showed, that if you want to go quick, you can go alone, but if you have to make progress, you have to go together. So it's easier to develop a program locally, but to do it country-wise and make it effective, you need inclusion of other people. And I was very much heartened to see the structure of the society as to what different people were involved in the process, in their leadership and participation. And even in this scientific program, you have participation from different parts of the country, and that would be very, very critical. I think one thing that COVID-19 has taught us, that we have developed this Zoom facility and virtual conferences. We probably would have never thought about it. I remember between our two separate institutions, Mark Rosenblum to put tremendous effort to have video conferencing so that we wouldn't have to travel between the two. But now, you know, we are able to have this conversation, and using this media, I think developing a tumor board that is across the country is going to be very valuable. You know, this morning's tumor board, I think again, people who listen to it prove the fact that you need different points of views and you learn from everyone to improve the care of those patients.
Thank you, sir, for your words of wisdom. As always, I will be thankful to you and grateful to you for those words of wisdom that you have passed on to me for the last 30 years. I will move on to Dr. Zarni Luen now. She is an associate professor of medical oncology at the Royal Brisbane and Women's Hospital and University of Queensland. Zarni has been past vice chair and treasurer of the Medical Oncology Group of Australia and a national executive member. She was lead investigator for the 2016 Australian Medical Oncologist Workforce Study. He is the current co-chair of the Society of Neuro-Oncology International Outreach Committee, International Scientific Organization Committee member for the 2021 World Federation of Neuro-Oncology Societies Annual Scientific Meeting, editorial board member for the World Federation of Neuro-Oncology Society magazine, deputy chair of the COGNO International Collaborative Research Committee, and chair of Cooperative Group of Neuro-Oncology, COGNO, Outreach and Education Committee, including the COGNO Outreach Education Program for Asia Pacific. He has convened national and international scientific meetings and was co-founder and co-convener of the COGNO Idea Generation Workshop for 4 years. He was the scientific program co-lead and organizing committee member of the Asian Society of Neuro-Oncology, ASM, 2016 in Australia, which attracted delegates from 20 countries. He has also been invited as a faculty member at international conferences and represents Australia on the Asian Society of Neuro-Oncology Reform Working Group. And I'm sure I've left a lot of things that I could have put in there. You know, if you want to get a lot of things done, with your woman, and she will do it. Multitasking, the amazing stuff that you have done, Zarni. Can you please enlighten us with your talk?
Thank you so much, Professor Inan, for that very warm and lovely introduction. Thank you so much for inviting me. I'm very humbled to be speaking in this session.
And we all know that you're joining from Australia at this point, so
that's right.
There's a difference in flavor right now, you know, compared to North America. So we have moved to the other side of the world.
Thank you, President. I mean, it's not yet midnight here in Brisbane. So I'm very honored to be speaking today, especially in this session with all of the esteemed speakers before me. Today, I will be giving a 10-minute snapshot about the Asian Society for Neuro-Oncology as my role as I serve as one of the ASNO Reform Task Force core members. So the history of ASNO was actually published in the Iano magazine in 2012 by Professor Matsutami from Japan. And the first ASNO meeting was actually in Kumamoto, Japan, and the original board members were from 5 countries. They were Turkey, Taiwan, China, Korea, and Japan. So a little bit about the journey thereafter. So as I mentioned, the first meeting in Japan was actually in 2002. And ASNO actually emerged after a request by the first WFNO organizing committee in 2001. In the first ASNO Congress, there were 142 presentations. After Japan, the Congress locations were followed by Seoul, Shanghai, Taipei, and Istanbul. Over the years, the membership has expanded. ASNO is based on country membership at the moment, and the countries that came on board included Southeast Asia, such as Malaysia, Singapore, also Hong Kong, Philippines, Indonesia, and Thailand. At the third quadrennial WFNO meeting in Yokohama, apart from the local Japanese hosts, there were actually 414 ASNO participants from 13 Asian countries, which shows the growth of the organization over the years. In 2013, ASNO was hosted by India, and this was the first time the Congress was hosted outside the first founding 5 countries. I think today it still remains the biggest ASNO meeting with over 600, I think it was 650 participants, which was a huge success. In 2013, Australia joined. However, ASNO has 50 countries within its borders, with still many countries that we look forward to welcoming in. So what is our aim? ASNO is a nonprofit organization to promote the development of neuro-oncology in the Asian region. It is truly multidisciplinary in nature. We would like to establish and promote high standards for the treatment of patients with cancer affecting the nervous system. We would like to elevate and sustain the education of all involved in neuro-oncology. And we would like to encourage mutual fellowship, goodwill, and scientific collaboration among physicians and scientists actively involved in the field of neuro-oncology. We are multidisciplinary in that we are not just doctors, but also include nurses, allied health, translational scientists, and also other areas of research as well. ASNO presidency has traditionally been based on the ASNO Congress chair. The ASNO Congress chair for the year would be the ASNO president. Our current president is Professor Ryo Nishikawa. And if we look at the journey, in the first ASNO conference, there were 142 papers presented. And as we moved along, in 2004, this grew to 582 papers. Our meetings are both abstract-based and also have sessions with invited speakers, and the Congress or the meeting usually is either over 3 or 4 days. Our current website is as on the slide, and Professor Rakesh Jalali is the ASNO website webmaster. Our logo has also been developed. In the first meeting in Kumamoto, this was the logo that was used. However, over the years, we also have now an official ASNO logo. And I'd like to just take everyone through the last 7 years on a little bit of a tour of the Asian countries that have hosted ASNO to share the vibes of the conference. ASNO is definitely expanding, and in 2020, we are welcoming Pakistan, and New Zealand is also participating as well. So in 2013, as I mentioned, Professor Rakesh Jalali hosted the ASNO meeting in conjunction with ISNO, with international faculty. And the meetings vary between the side meetings as well as the scientific content. Sometimes there are consumer forums, sometimes there are pediatric neuro-oncology forums, sometimes there are forums with carers as well. That followed the following year by the Congress being hosted by Turkey in Istanbul. And after that, the conference was hosted in Manila by Professor Manuel Mariano and also by Dr. Juliet Batara. In 2016, Australia hosted our first ASNO. This is Professor Mark Rosenthal, who was the chair of Cogno at the time. And in the spirit of Australia, at the welcoming cocktail reception, we had an Australian koala, we had a baby kangaroo or joey, and we had a python as well. The baby crocodile had been double booked, so didn't make it on the day. And we also had the University of New South Wales Medical Music Society play with a quartet that all consisted of medical students. The following year, ASNO was hosted in Osaka under the auspices of Professor Nishikawa and also Professor Yuichi Hirose. There were amazing content, and there is also always a very, very strong presence of pathologists in ASNO with a very strong pathology content session as well. This was followed by Beijing under the guidance of Professor Zhongping Cheng. And as always, the conferences not only consist of networking during the sessions, but also afterwards in the dinners and also cultural exchange as well. There was an amazing, amazing reception with a portrayal of culture there, which we thoroughly enjoy every year. In 2019, we had a special meeting in Seoul, and this was organized by Professor Yong Kil Hong, Professor Seo Kim, and also by Professor Cheong Kim. And this was really to bring all of the ASNO Reform Task Force together in a face-to-face workshop to discuss the future and the evolution and the new changes required for ASNO. The discussions carried on to Taipei. This is Professor Wei and Professor Wong. And in the business meetings, the main issues that came about were that we will be going through structural change. The Reform Task Force consists of really dedicated members. We are working together at the moment. The structural change will include an ASNO executive board, an ASNO president that will serve by term, and a separate Congress chair for each Congress that occurs annually. The bylaws are being developed, and we are also moving from country membership to individual membership. We have new committees being developed. The office space will be in Korea, and we are looking forward to also having clinical trials. We also participate at the Society of Neuro-Oncology ASNO Sunrise Sessions. This is an ongoing annual event with robust scientific discussions to showcase cutting-edge research from Asia, but also within the clinical nuances that are relevant to the Asian context. Also, as Chaz very eloquently discussed and showed in his previous slides, for the Neuro-Oncology Practice Journal, which is a journal of our society, Society of Neuro-Oncology, ASNO has an executive editor, which is Professor Rakesh Jalali. The 2020 Congress was supposed to be hosted by Indonesia in Bali by Dr. Rini and Dr. Henry. However, with COVID, as with most other conferences, this has been postponed to sometime in the future. So I just wanted to give a snapshot of what ASNO is about and just to give a flavor of the development of ASNO in the last couple of years. I would also like to thank and acknowledge Professor Ryo Nishikawa and Professor Rakesh Jalali for helping me to develop these slides. Thank you very much.
Thank you, Zarni, for giving us this sort of regional history after Chaz gave us this world history. And, you know, all those people that you talked about, some had sent messages to us welcoming PASNO. And this is all because you were important in networking. And networking is very important part of all these societies. So people like you, people like Jalali and Hilare, and, you know, all these people, they just do an excellent job in that one. So I'm going to move on to the most important aspect of PASNO. And that was also, and I'm so glad Dr. Rosenblum brought this whole history, eventually focusing on that aspect. And that is about patient. We we talk about surgery, we talk about techniques, we talk about research, we talk about academics. All that is periphery. The center is the patient. It's all for the patient. And I'm honored that I have two guests today who have agreed to give us their opinion. Both of them are highly intellectual, intelligent, sophisticated people, and their resilience and persistence, vision is just amazing. Uh, will start with Mr. Yasser Latif Hamdani. Mr. Yasser actually is not feeling well because he's going through radiation right now. He was very kind to agree that he would do it, but then we have his wife, Mrs. Aisha Sarwari, who will represent him. But they have been together in this journey, and both of them are just a pleasure to talk to. One of the most intellectual people that I have come across. Yasser Hamdani himself is a lawyer, a human rights advocate, and an author. When YouTube went down in Pakistan, he was the one who fought for it, brought it back. His book, Jinnah, A Life, was published in 2020 by Pan Macmillan. And I can proudly say that this was written after his first awake craniotomy that I did in 2017. So I did a good job right there. That he wrote this excellent book. By the way, I still have to receive a signed copy from him. Yasser lives in Islamabad with his wife, Ms. Aisha Sarwari, a mother and two daughters. He tweets at the real YLH. Since he could not join because of the radiation therapy he was feeling down, we have Aisha Sarwari, who has graciously accepted to represent him and talk about her experience and what we should do in PASNO. Aisha, please.
Thank you, Dr. Atharanam. It's an honor and a pleasure to be part of PASNOV, and actually on behalf of Yasser, so I wanted to thank the organization and all of you for giving us the opportunity. I think.
Yeah, you may want to try again, Aisha. There was some problem with internet.
Yes, yeah, I think I got offline. So I just wanted to thank you, and I'll dive right in if you can hear me.
Yes, we can, please.
Okay, so I'm going to start sharing a Microsoft PowerPoint with all of you. Let me know when you can see it.
Yes, we can see it.
All right. So this is Yasser Latif Hamdani, my better half, somebody who has journeyed with me for over 20 years in life. He unfortunately cannot be here. I had a chat with him before I was arriving here to ask him some questions about what to share with you from a patient's perspective. And I don't think it gets any more real than a personal chat between a husband and a wife. So I asked him, I was like, any points? So he wrote to me, points from me, brain tumor is hell. Brain tumor sucks. I hate brain tumor. I said, okay. He said, the last 3 years of my life have been pure hell. And I said, okay, can I ask you specific questions? He said, sure. I said, why did you not give up yet? 2, what's the worst thing about the brain tumor? 3, did any growth take place spiritually or emotionally because of the tumor? Was there any growth despite the tumor? What parts of your mental health struggle would you like the world to know? He slowly started explaining, because obviously the whole first part about everything being hell is not very useful. He said, family keeps me going, as does ego. And Zoya, who's our first elder daughter, he quotes her and he said, he has so many dreams. He said that line by our daughter, it doesn't let him give up. He said, that doesn't let me give up, though the thought does cross my mind. I said, what would you wish your family to know about the struggle that you're too embarrassed to admit? I asked, what movie do you think that your protagonists that you're a protagonist of now. I asked him, who do you think of when you fight on? And I said, describe your mornings. He wrote, the worst thing about the brain tumor is the years wasted. I don't think I'm ever going to get those years back emotionally, professionally. I asked, if somebody could guarantee 20 more years, would you take it? And what guarantees would you want if you had 3 wishes? And I asked, what are the craziest moments of your first awake craniotomy? He said, no growth took place because of the tumor. I only regressed into something less honest than myself. Now you have to understand he's going through a lot of radiation and he's unwell, so his state of mind is less positive, but usually he's quite the fighter. I continued asking him questions. I said, what were the most scientifically glorious moments of your experience? What would you say to Dr. Athar Inam? Do you want to stop treatment and opt for palliative care? Why not? What role does love play in the disease? Here's something I think he said, which was very important. He said, OCD, obsessive compulsive disorder, is the one thing, he said, that I would like the world, that I won't want the world to know. I know that my psychiatrist does not agree, but I do have OCD, or something called pure O, or pure obsession. And as you all know, the difference between OCD and pure obsession is that pure obsession does not have a compulsion that gives the patient reprieve or end. Yasser keeps going into loops of thoughts about yes answers or moral questions or right or wrong, and they just don't end. And it's so exhausting that by the end of the day, he cannot pick up a glass of water. I said, what are your 3 primary symptoms? And to the question where I said, what movie would your life be? He said, Anand, it's a Bollywood movie. So those of you who know, he said, that's the movie that he feels he's the protagonist of. I asked him, who do you think of and not give up? He said, I think of Jinnah, who's our founding father of Pakistan, and you, which is me, to fight on. And I asked him, why Jinnah? And to the question that he said, describe your mornings, he just said, my mornings suck. As you can see, he has a bit of a dark humor there. To answer why Jinnah, he said, because he fought a deadly disease of his own and kept fighting. Our founding father, Qaid-e-Azam, had a terminal illness and he kept fighting to create the country that we have now. And I think that powers him on. I asked him what songs describe 2017 and beyond. 2017 is when he got his tumor diagnosed. Obviously, the questions are coming not in the order that I was asking them, but he said to the question that if I could guarantee 20 more years, what would he do? He said, yes, and that I should achieve all my dreams and that my family would be safe and okay. To the question that I asked, what are the craziest moments of your first awake craniotomy? He said, being awake with your brain being cut up. I asked, lots of people have gathered to cheer and support you. How does that feel? And I think this is when he starts answering the questions one by one. To the question, what are the most scientifically glorious moments of your experience? He said, awake craniotomy itself is a glorious scientific moment. To Dr. Athar Inam, he said, thank you for giving me life, for what it's worth. To the question about stopping treatment, he said, I would have treatment just to fulfill my dreams. To the question, what role does to the question, what role does love play in a disease? He said, love is all, like destiny is all. To the question, what are the 3 primary symptoms of OCD? He said, rumination and the loops of rumination. To the question that he said, a lot of people have gathered to cheer you up. What does that feel like? He said, I feel deserving. And then I asked him about a question of history, which he didn't really respond to. To the question that, what would you like our daughters to know and our youth of Pakistan to know? He said he wants a better and a more inclusive Pakistan. And I said, what picture would you like me to show everybody? He said, picture of me and the cat. He really loves animals. So I'm going to show you that. And then he said, don't forget to mention the important people, Zoya, Zainab, and mom. That's his daughter and his mom. And I said, how do you want to be remembered? And he said, I don't want to be remembered. He said, please tell everyone that I won't wish what I've gone through on my worst enemy. So, ladies and gentlemen, thank you so much again for allowing me this. And I just have a few recommendations as combined with Yasser and myself to give you in this experience that we've had, which has been fantastic. And Dr. Athar Inam, I think, is more than just a doctor. He's allowed us to be a one-window operation from end to end. He's been our psychiatrist, he's been our pep talker, he's been our mentor, and he's also been our lifesaver. My recommendations are that doctors and surgeons are co-creators. So please do see yourself as that. You are taking part in God's amazing creation process. That nursing care is pivotal. I really think that right after brain surgery, it's very important to put the patient into a very low stimulus environment. Anything is distracting. So as low as the stimuluses are, the better is their care. The brain tumor creates complicated grief for the patient and family. There's grief when somebody is lost, or somebody's getting tired and somebody's getting older, or somebody's losing their life. But it's complicated grief when it's a brain tumor, because the person reverts to being different people, sometimes mean people, and sometimes people who are difficult to be with, and then they become not themselves. So it's very complicated for the patient as well as the family. So I think it's very important to understand that. The remedy is in the holding of the patient till the end. I think Dr. Inam is a great person to do that. I mean, from quoting movie lines to recommending books, I think he's just more than somebody who cuts open a brain, And I think the most important thing is to push the glioblastoma as far off as possible. That possibility
Aisha, you're mute.
Am I back on right now?
Yes, you are back on,
Okay.
Aisha.
And let me know if you can see the screen in 2 minutes. I'm sorry about the internet connection.
Yes,
it's a little unstable, like everything in our lives these days. All right, can you see the screen?
Yes, we can.
Okay. I think it's important to know that there's more than just the medical aspect of this. There's the psychological, the psychiatric, the epileptological care that have to be in tandem with the opening the brain and doing the care. And also that the patient is only as strong as his or her caregiver. There's no point in doing so much investment in a patient's brain tumor surgery if their caregiver is not equipped to then take them home and give them water, So I think that part of it is also very important to look into. And lastly, it's very important to know when to stop relying on the patient's natural ability to bounce back. A lot of times I hear people say, oh, let him grieve. He's gone through post-traumatic stress. He'll come out of it himself when he's done grieving. But the thing with the brain tumor is that your entire capacity of your natural abilities to heal naturally and to let the body's processes work are marred. So it's very hard to do that. And I think it's important for doctors to understand that. And lastly, special thanks to from Yasser to the people here, his mom, Dr. Dirshawar Hamdani, his daughter Zoya and Zainab, my family, Dr. Arif Sarbari, he was one of the first graduates of Aga Khan University and who's the chairman of the West Virginia University Hospital at the moment, who held us through this process. Atif Sarbari and his bhabis, and obviously last but not least, Dr. Athar Inam and the AKU. And this is the picture that Yasser wanted you all to see of him calling for the cat and the life that I think animals and lovely things bring back into our life. So thank you so much for allowing me and him to be part of this.
Thank you, Aisha. No matter how much we speak, we still can't get to really the core of all the feelings and everything. One has to go through it to understand that. But I think communication is an important aspect, and you guys are so good in that one. By the way, that picture of cat, is that Yasser's cat?
No, we were in Aga Khan Hospital, and I used to take him for walks by force. And so this was the hospital cats in the periphery, in the gardens. Yeah.
Stop right there, because president of the AKU is right here. He will not like that there's a cat roaming around in Aga Khan. So we did not see any cat, Aisha. There was no cat.
It was way on the other side of the periphery, not to worry. Okay. And we were outside.
Thank you, Aisha. So I'm gonna move on to Ms. Komal Sayed now. And Komal Sayed, I took care of her husband, Taha Rafi. Again, I have been blessed to come across people like you, intellectuals, intelligent, learned, rational, logical. And I remember Taha was definitely like that. And so is his wife, Ms. Komal Sayed. She's an ex-volunteer with the Brain Tumor Foundation of Canada. So she was here taking care of Komal, and then after taking care of Mr. Rafi, and then Mr. Rafi, when took his final journey, she moved to Canada. She tried to establish Brain Tumor Foundation of Pakistan, which was a great initiative, and I think it's going to work great. She has been busy with the issues of brain tumor patients. She finished her MBA from INSET in France in 2018. After this, she took care of her Mr. Rafi in 2015. And she currently works in Luxembourg as an employee of Amazon management, employee of Amazon. So that's a great country to be, Luxembourg. So Komal, can you please enlighten us? We're all here to listen to your perspective as a caregiver.
Thank you. Thank you so much, Dr. Anam, for the kind introduction. Good evening, good morning, good afternoon to everyone, wherever you are in the world, and Assalamu alaikum. It's really, really an honor, Dr. Anam, to be here and to be invited. I have never actually spoken about this experience at a forum like this before. So it's going to be very raw and from the heart, and please excuse any slips. So as Dr. Nam said, I'll be sharing in the next 10 minutes from more of a caregiver's perspective, and try to just reflect on, of now 5 years on, just how I feel my experience had been. So in 2009, I married a man who was young, who was smart, who was confident, empathetic, handsome, and most importantly, he was very healthy. And he was sort of my backbone. I was 24 at the time when I got married. He was 32, so he was 8 years my senior. I used to look up to him in a number of ways, in terms of, just how he carried himself. He had a very magnanimous personality. My words will not do justice to how Taha was. But also, how he was progressing in his career. I was just in awe of how he was leading his life. Little did I know, or little did we know, that 3 years on, in 2012, Taha would be diagnosed with a GBM, and the roles would be reversed. So basically, I mean, if I think of the experience and every step and every stage of that journey, I can literally recount every single detail. It's so clear in my mind, even today. It feels like it happened just yesterday. I remember just initially, I'll share a bit from the initial part. He was diagnosed in October 2012, and I still remember how he was diagnosed. He called me at work on a Monday morning to say that I'm at home, and I said, well, haven't you gone to work? And he said, well, I have a really bad headache. And in my mind, it wasn't enough to just not go to work because you have headaches. As I said, well, go to work. You probably just need to get your eyes tested, and we'll go to an optometrist in the evening. And he said, okay, fine. We went to optometrist. Obviously, that everything was fine there. He missed work that whole week because he had this massive headache. And on Thursday, he called me at work to say that, Komal, I need to meet a neurologist. And it just did not connect. You see, like from just having a headache to saying I need to meet a neurologist makes no sense. At least in my mind at the time, it made no sense. And I said, you're just like, or over like, we'll just go to another doctor, we'll check with an ophthalmologist, maybe the pressure in your eyes is off. Anyways, we managed to get an appointment on his insistence with a neurologist at AKU. And initially he was also diagnosed with a bad case of migraine, and he was given migraine medication. And Taha insisted, after taking migraine medication, that take me back to the neurologist. It's not a migraine. And I don't know if our bodies somehow tell us, there's something wrong, but somehow he knew. And he said, I need to go meet the neurologist again. We did. And Taha insisted that he wanted an MRI because he didn't think it was a migraine. I assume it's not protocol to send someone for an MRI just if they have, a headache. So I'm assuming that that's why he wasn't initially sent for an MRI. Sure enough, when the MRI came back, we were told that he has a brain tumor. We didn't know what type, but we were told that he has a brain tumor and he needs to be admitted right away. I like I said, I can recount every little step as though it happened just yesterday, but I won't. What happened is just, I'll try to summarize and then move on to a few of my reflection points. But post him being diagnosed, we were fortunate enough to meet Dr. Athernam's team. Taha had what Dr. Athernam had told us would be in a week, literally in a few days of him being admitted. He had what Dr. Athernam called a procedure, a small procedure, but for us felt like massive surgery. It was a 3-hour procedure, but those 3 hours were extremely grueling. And after that procedure, when the results came, we were told that he does in fact have bigger tumor, and it's a GBM, and he needs to go for a resection, so surgery, to have it removed. That surgery was much longer. I don't know how, honestly, I do not know how Taha's family, my family, and myself sort of managed to just keep ourselves together through that. It was a 9-hour surgery, and Dr. Athernam performed it. We after the surgery, I mean you're all in this field. After the surgery, Taha then went on for radiation and then chemo. We opted to go to Singapore for radiation and the initial chemo, and then we came back to AKU for continued chemo treatment. We were in that sense quite fortunate to have resources and the network, or just resources to be able to look at options and then assess and then decide, right? But I remember when I walk into those waiting rooms with Taha, we would, both of us would wonder that how is everyone in this waiting room actually dealing and coping with the disease? Because you could tell the people who the other patients who were there would have come from very far-fetched areas in Pakistan, or might not have had the funds or the resources that we did at the time. So it used to make us think. It used to make us think quite a bit, and we realized that we were in a position where we were fortunate to have access to doctors or to networks or to just resources to be able to go through his treatment and not worry as much about how is it going to get done. We just needed to figure out what needs to get done, but just that part itself was so difficult on its own. Unfortunately, Taha didn't make it through the journey, as Dr. Athernam mentioned. He passed away in November 2015, exactly 3 years after he was diagnosed. And if I'm to be honest, we lost him in November 2015, but I lost him much before that. He wasn't that strong, confident, opinionated man that I had married. So soon after the initial surgery happened, there were slowly just very minor changes in his personality. Initially, it was just his mental state, his level of confidence that changed. But then over time, of course, it became even physical. I try to reflect now, and I try to, it's been 5 years. I try quite a bit to reflect on, how maybe to reflect, to accept, and also to see how maybe I could have maybe done something differently or something better. I know that obviously I have the benefit of hindsight right now, but and I know that in the moment I did the best that I thought at the moment. Um, but I always still wonder that what if I'd done this differently, or what if I'd done that differently. And with that in mind, I try to put my thoughts together so that maybe somehow through my experience and through Taha's journey, we're able to support or help someone else and make their journey smoother. Because if I feel like if we're able to, even through this experience, help one family or one patient and make their experience better, I'll feel like I achieved something. So I'll just share a few of my thoughts over here. I'll just share my screen. Just 1 second. So let me know if you can see my screen now.
Yes, we can.
Okay, great. So when I reflect and I look at as a caregiver, and I'm trying to make sure I stick to the perspective of the caregiver. I didn't realize it then, but I realize now that being a caregiver is and was a full-time role. I was working full-time at the time. Taha was also working, and then post-surgery he sort of weaned off work, and he's started staying home. But I was working, and I was trying to manage just being there for him and caring for him, but there were a lot of other sort of facets of being a caregiver which I just sort of took in the flow, and I didn't really sort of understand and realize that they require a lot of effort and just more focus. I mean, his last year actually, when physically Taha deteriorated, I did take a sabbatical from work, and I feel that's one of the best decisions I made in my career, to take that sabbatical so that I could be with him, and be a caregiver more, full time, and be there for him at all times. But these thoughts that I've put together, they're just bullets here, but I'll speak more to them. So the first one is access to information and awareness. Just that initial example I shared, when Taha had the headache, and I brushed it off, and I said, oh, it's probably just your eyes prescription needs to be, glasses prescription needs to be changed. We weren't even aware of something by the name of a brain tumor. Had zero idea. For us, all cancers it's cancer, right? But I think I was speaking to Aisha earlier this week, and she said there's cancers and then there's brain cancers, and it's so true, because they're just completely like it's a world of its own. And access to information, everyone has access. Well, not everyone. We were in Pakistan at least lucky enough to have access to the internet and access to information that way, but it's a double-edged sword, because Taha also had access to the internet. So when he knew that he had a GBM, he started researching, and it's very challenging and difficult to make sure that the patient stays positive despite reading everything that's out there. So there needed to be some form of filtering information and making sure that we don't overwhelm ourselves and are able to just go sort of with the flow. So that's one of the things I feel is important. The other one is, which I'll talk about a bit more, is navigating the medical system. I remember to get that first appointment with the neurologist, and through that the chain of being admitted to hospital, having an MRI done. To get that appointment with the neurologist, when I called the clinic, it was like 6 months down the road, because the in Pakistan, unfortunately, the supply of doctors in this field and the demand and the need is there's a mismatch. So when I called, there was a 6-month lead time, and I was just lucky by chance, because one of my aunts works at AKU and knew the doctor, and she was able to connect us, and she said, he said he can see you really quickly, so we ran. I mean, what about the people who don't have that kind of network or those resources? How are they managing to get time with doctors? So that was one of the things. The other thing is, Dr. Mark Rosenblum, you mentioned in your talk, and I'm grateful to you for mentioning that, but you said it's very important to see the disease through the eyes of the patient. And I don't know how as part of formal training for doctors, if it's even a part, like the whole empathy and compassion. And I'm not sure how it's done, but you can sort of spot it from a mile away. when you meet a doctor, the first meeting, you realize right away how compassionate and how empathetic they are. And we were, again, in this case, extremely fortunate. We had Dr. Atharnam for as Taha's surgeon and his team, and then we had Dr. Adnan Jabbar, who was Taha's oncologist. And both these doctors and their teams, I feel like they literally went above and beyond what their role was, beyond when Taha's surgery was completed, and beyond when we decided to stop chemo. Both these doctors were still involved, and if I messaged them, they would reply right away with questions that really I shouldn't be using their time up for. But it was because there probably wasn't this external non-medical support that I had access to. I didn't even sort of have access to other patients or anyone else who was going through something similar. So I had zero idea who to reach out to, and I'd reach out to them, and they were extremely supportive throughout this process. And I mean, we did travel abroad. We got a lot of second opinions, so we had access to a lot of different doctors. And some of, I don't know if, like, it's a very important that when I suppose when doctors communicate, that they share that compassion and empathy, because when it's not there, it can be really sort of brutal for the patient's hope and their well-being. I remember, and I won't forget, there are two comments that two doctors made to Taha. One was tried to set Taha on a clinical trial, and Taha asked that I'm not sure if I should do this, and the doctor like Taha was sitting right there, and he told him, he said, well, if you don't start this tomorrow, you won't survive past 6 months. And I can't imagine having my husband hear that, because it's debil, like it's traumatizing, debilitating. Like, I don't know how he was processing that. And I was, after the meet, like after the appointment, trying to tell him, no, just that's his opinion, try to not go with that. But these are like such harsh words. Another time, I think Taha asked, how long will the treatment last? And he was told that the treatment will last for as long as your body can take it, or as long as you can financially afford it. These are very difficult. I mean, I feel like they might be very pragmatic and sort of practical things on paper, but it's very difficult for a patient to hear that. And as you mentioned, Dr. Rosenblum, it impacts the health and the well-being of the patient. And it's very important to realize how to sort of phrase these points, even if they're if they're the honest and harsh, if it's the harsh truth. So those, for me, I think, in terms of navigating the medical system as a caregiver, I also just trying to get time, in the doctor slot. We would meet Dr. Adnan and Dr. Inam, once in 2 months, and it would be like a 10-minute slot where I knew there'd be like an overload of information from the reports. And I would sort of have a list of questions that I'd be preparing, so that to make sure I don't miss out on that 10 minutes, and make sure it's as effective as we can make it. But it's challenging to do that, where if a doctor's not as so I suppose as compassionate or helpful in wanting to listen or support. So in our case, I think the reason we ended up choosing Dr. Naam and Dr. Adnan was because Taha felt good with them. And really, as laymen, we don't understand credentials or like certifications, etc., which with school a doctor got their degree from, because as not in the medical field, it's hard to grasp that. But we go with word of mouth, and we go with how we feel when you meet a doctor. And I think it's so important to understand that from both perspectives. The third thing was about financial impact. Now Taha was working with the World Bank at the time. He obviously stopped going to work, but we were fortunate enough that he had medical insurance, and that he was then getting short-term disability and then long-term disability. So we were, as I mentioned earlier, able to sustain or manage his treatment without really impacting, from a financial standpoint, our lifestyles. However, I don't think this is, the case for everyone, and it's important to try to understand or grasp as part of, access to information awareness of how this disease will financially impact, the journey or the lives of the patients and their caregivers. And that brings me also to, trying to be there for for the patient in all of this, trying to deal with the information, trying to understand how to navigate the medical system, trying to figure out insurance or finances. You also need to be there for the patient. And to be there for the patient, I remember initially when Taha would have memory sort of lapses, there was a point when he started forgetting who I am and that I'm his spouse. And I remember it would it would be initially it would bother me, and I would try to remind him and try to just show him pictures and show him the wedding ring and say, hey, remember we got married, and he'd be like, oh yeah, but I realized that that wasn't fair on him, because then he would feel bad. He'd try to he'd start doubting himself, be like, why didn't I remember, how could I forget? So then I decided that, what, I need to just support him with his journey. And if he forgets, it's okay. So then sometimes he'd call me by another name. I'd just go with it, because I was like, instead of trying to correct him and trying to, set the reality, it's okay. His reality is his reality, and it's fine as long as he feels good and he's feeling happy. Uh, and aside, I think I feel that in Pakistan, we were in Pakistan, our culture is quite tight knit, and our so our social culture is very tightly bond. We have tight bonds within the family. It's very hard to, I say I was his caregiver, but it's very hard to determine who is the real caregiver or who is the main caregiver, because there's a lot of people who are very close to the patient, from different relations or friends or etc. And it's very hard to determine, who is going to be that main caregiver, and then trying to manage those expectations with everyone around you, and also manage information flow, because that after an appointment it would be like an overload of messages asking what happened. And I try to then sort of set like a system. I tell one person in the family and ask them to then relate to everyone else in the family of how the appointment went. But I remember it was a bit challenging by default. I mean, I was a spouse, so I was one of his main caregivers, but then there were also a lot of other caregivers. Eventually I was his primary caregiver, but it was just this very difficult discussions that a caregiver needs to go through. And I think it's important to realize that it's okay, if you have to go through them, because at the end of the day, it's the patient's well-being that really matters. And if you need to be a bit harsh in certain fronts to make sure that patient's well-being is taken care of, then so be it. So it's just a bit tricky, I think, managing these different situations as that caregiver. And finally, last but not least, self-care. One of my close friends at the time told me that you should speak to a therapist. And I said, I'm fine. I don't need to speak to a therapist. I'm fine. And I was trying to be very pragmatic through the whole journey, and just going with, the next thing that needed to be done, and not trying to sort of, to just try to dwell too much on what's happening, because I realize if I start doing that, it's going to incapacitate me. But I said, I'm fine. I don't need a therapist. But I eventually did, go ahead and seek a therapist. I seeked a therapist first for Taha, because I didn't know, there was a point when he just stopped speaking, and I couldn't understand if he's speaking because, on that day, maybe he's just upset with me. Like, it could just be, just a day thing. Or is it because he's depressed? Like, maybe he's just getting very upset about the situation in general. Or is it that the tumor has gone to part of his brain, which is not allowing him to process thoughts? So it's just so tricky. I still don't know, to be honest, at some points, if he wouldn't talk, which one of these three it was, because he just stopped communicating at some point. So we did get a therapist, and he spoke for a bit, but then after a while, when he deteriorated quite a bit, he wasn't communicating with the therapist either. But then I started meeting the therapist, and I think it was quite helpful to speak to a third person who was not involved with the situation, of not be impacted by the things I said. And it's hard to accept that, because you feel like, oh, well, I'm fine. But I think it's very important as a caregiver to take care of yourself. For me, after Taha passed and I moved back to Toronto, I started volunteering with the Brain Tumor Foundation of Canada. I did this primarily for just to connect with more people who are going through the same disease and through the same journey. And I used to run support groups over there on a monthly basis. But through this experience, what I started realizing, I questioned and came back to the initial thought of when Taha and I used to see all the patients in the waiting rooms. We realized that through my experience at Brain Tumor Foundation Canada, I just wished and hoped. I was like, wow, I wish something like this was there for us when we were in Pakistan. There is so much non-medical support available out there, which I had zero idea about. And I wish I had it, when and Taha had access to it. But then I thought that, okay, well, we didn't. It's done. But what about if now, like, what about the patients still in Pakistan going through this, people who are not as educated, who don't have access to the internet, who don't know how to reach out? What about providing them something like this? And Dr. Nam mentioned briefly about trying to set up the Brain Tumor Foundation of Pakistan. It was initially just a thought, but I'm thankful to Dr. Nam. But basically, I'm going to try, under the PASNO umbrella, try to initiate this foundation again with that sole intention of trying to make the journey of those impacted in Pakistan with a brain tumor smoother or easier than it was for Taha and for me. That's basically what I wanted to share. It's been 5 years. I won't say I've moved on. I really don't like using that word, because I feel like a lot of people say, oh, have you moved on now? And you'll never move on from something like this, because it's part of me. It's really a part of me, and it's not about moving. I don't want to move on, because I feel like it sounds as though I'm trying to like push it behind. Although I feel like maybe I prefer saying that maybe I'm moving forward with like trying to take what I've experienced into another phase in life. But thank you for listening. What I would just request is there's the audience and the participants who are here. I heard all of you from earlier today, and it's been very insightful listening to everything. I would just like to request, I'm sure from you're all from a host of different countries, there are similar foundations in your countries, and if you feel that you have ideas which would help us to establish and set up the Brain Tumor Foundation of Pakistan effectively, please do reach out. I think it would be very, very helpful for us as we set up this initiative. But thank you, thank you for your time, and thank you for listening.
Thank you, Komal. You rightly said you don't want to move on. I mean, I don't want to move on even for my parents who passed away. I don't want to just move on. So how can you do for someone that you had so much connection with? But I think what you and Aisha and Yasser and everybody's going to provide is really let us think as doctors and surgeons. What is the reality? How we should look through your eyes, as Dr. Rosenblum said. And I think things organized under PASNO with this foundation, I think we will serve the real purpose of PASNO. So thank you very much. I'm going to move on. We're going to do quick because Dr. Samin Siddiqui is here, and I asked him to talk about it. So whatever you talked about, Komal, and what Aisha talked about, it all relates to patient experiences, and we don't know what is the really what kind of as Sun Tzu said, know thy enemy. So we don't really know that enemy so well. So epidemiology is one of the very important that we need to have. I had a big presentation. I'm just going to cut it down to just a couple of slides, but letting you know that with Dr. Samin Siddiqui, who is the chair of CHS and an international figure in community health services, we have started this epidemiology study on the platform of PASNO. to collect the data for brain tumor patients. And although the Pakistan Brain Tumor Consortium is about 50 centers, but what we have at this point is just few months of data collection. And we are already trying to understand the monster that we are dealing with. So instead of going over each slide in detail, I'm just going to skip through a lot of things. And we talked about neuro-oncology. We talked about the global issue that the 50% of world's population live on less than $2.50 a day. That's the problem that we're facing. The patients that have to move all the way from Pakistan to different centers, big distance issues. Private hospitals are expensive, but then the other hospitals, which are not private, they have other issues, lack of hygiene, long waits. So both have their own problems. We do have a lot of welfare in, and AKU gives in a lot of, it's $24, $25 million a year, and there are other hospitals that give that. But then the insurance in Pakistan and India and Bangladesh is very low. And then that puts patients under the catastrophic expenditure. So Komal, you were lucky, and Aisha and Yasser are lucky in that sense. But then the majority of the people don't have that kind of financial support. And the 25 million people household are pushed beyond poverty line. That's a global surgery figure, not only brain tumors, but in general. And of all the catastrophic expenses, the tumors are the main one, the blue ones. These are the main ones, and they're projected to go up higher. So, and then you mentioned about that, Komal, about the doctors and patients. Pakistan is the worst in that. The number of patients per oncologist is the worst. This is the median average. This is what we have in Pakistan. So you can imagine how it becomes so difficult. But then at the same time, we can't just take a square peg from a developed high-income country and push it through a round hole. We need to develop our own guidelines and all that thing. And that's why we need a consortium. Past now, we need to avoid expensive things. We can do something cheaper, better, like use the forward without high-end technology. And this is Dr. Malik who taught me before I came to Pakistan. You need to learn how to drill it without a power drill. And I learned it from Dr. Malik. He said that going back to Pakistan, you need to learn that maybe you will need it. So we need to have research, clinician researchers, and the training has to be done. Interdisciplinary Neuro-Oncology Tumor Board has to be done. That is what Noreen Mushtaq is doing with Eric Buffet already. Telemedicine is important. Virtual biopsy and artificial intelligence is important. Liquid biopsy is important. We are trying to put it all together for economics. Brittany Pope gave a very good lecture today. That is very pertinent for Pakistan to cut down the cost. And then very important to know the molecular epidemiology and registry. That's what we're building up. If you look at this map, we don't have data from here, from Pakistan, really. We have data from Rakesh probably is the person who did that, but we don't have data from Pakistan. And then we can't just assume that whatever is in Pakistan. If you look at COVID, this is how United States is going, this is how the world is going. And India and Pakistan are so similar, but then the trajectory is different. So we can't just extrapolate things from there. And that's why we need consortium and talk about these things. So I'm just gonna talk about that, just mention that we have few centers who have started to collect. We have about 50 centers that in a consortium. We have some data that's coming in. I'm not gonna go through all but then Dr. Samin has seen all that thing. The interesting things that came up in this initial data, we may have about 8,000, 9,000 or 10,000 patients. So far, we have 600 patients. But interesting thing that's coming up that the glioma EM is much lower in Pakistan for some reason. The median age is younger in Pakistan, and this is as expected because the distribution in Pakistan of the socioeconomic group, 3% of history with familial disease, and another important thing was, look at this is the last slide, is that the patient that come to a surgeon over here, then they take their file and then they go to somewhere else, then they get the radiation, then they go and have somewhere else and go there get the chemotherapy. We don't know if they got all that or not. And in the beginning of the session, I mentioned about that one patient that came back after 4 years, and because there's some kind of a lack of central arrangement for these things. So if you look at it, this is the data, not a good data, it's bad data. That about 60% plus patients, we don't know if they got a chemotherapy or not, but whether they got radiotherapy or not. That is not good. So that will be a big challenge for PASS now to begin with, to start to standardize things. So I will, Dr. Samin, can you? I need your commentary. You're the expert on this thing. I'm not an expert of it.
Well, first of all, thank you very much, Inam, and this has been a great session. And I can see there's a galaxy of some very distinguished neuro-oncologists, neurosurgeons, and so on and so forth. And thank you for asking a public health person to come and give a quick. I'm going to give you a 3-4 minute reflections on what has been, and I've learned a lot in the last few hours, I must say. But let me start by what one of my major, is how surgeons in general are moving on and have such a good public health perspective that what it used to be 20 years ago or 25 years ago. And I think that is becoming so important. So the whole global surgery movement, and I know you organized a very successful conference 2 years ago or less than 2 years ago on global surgery, and now you're doing one on neuro-oncology. I mean, these are the, in our part of the world, these are uncharted areas which we are now trying to address, and I think this is a very, very good way to go. Second, I think the fact that you're bringing together institutions within Pakistan and trying to establish a network, which I think is great, and I could see many people from Pakistan who are there. So that's a very, very positive sign, and I hope we can sustain it and we can continue this. Clearly, we have very little information on the epidemiology of the disease in Pakistan and in general in the low and middle income countries, but I think a start has been made. And I think that would need some analysis, and we will be very pleased as we are working with you to be able to get a good picture of what the situation is in terms of the epidemiology. But I think what Komal Sayed's talked is what I wanted to talk about, and I think she did in a very eloquent manner than I would do now, but I would still touch on some of those issues. So I think the next step, once we have gotten a handle on the epidemiology or we understand what the situation is to see what is the response that is happening in terms of addressing the challenge of brain tumor in Pakistan, in South Asia, and in low and middle income countries. I think that's the key. The key question, I think that from a public health perspective, is how we can make neuro-oncological services accessible to the population in need in low and middle income countries. I think that's an easy to ask, but a challenging question to answer. But I think the collective wisdom of this kind of group can begin to answer those kinds of questions in a situation where we work. So from a public health perspective, I would put 3 or 4 points for the consideration of the group and for you as well, and as this whole area moves forward. First is there's no question that we'll have to work more to understand the epidemiology, the risk factors, the burden of disease, the kinds of tumors that we are seeing in the north, in the south, and so on and so forth. And I think that'll take some more time, but the work has started. And I think the registries that you're trying to develop and establish are absolutely critical. So that we don't only have cross-sectional data of how many cancers we have and what kind of, we can actually work out in a longitudinal manner what is happening in terms of outcomes. At the moment, we don't have any information to my mind, and correct me if I'm wrong, in terms of what is happening in terms of outcomes and the quality of the treatment and so on and so forth. So I think that's some work to be done, both to look at cross-sectional data, but also to do some longitudinal work. And I think we at the centers in Pakistan and South Asia, I think should work together to be able to start looking at that. The second would be, and I have perhaps touched on this, but let me say, would be to map what is happening in terms of responding to the challenge of brain tumors in Pakistan, referring again to the LMICs. So how many centers are there? But that's not enough. Not just having the name of the centers is not enough. What kind of neurosurgery is being done? And you guys are the experts to tell what kinds of things are being done and what needs to be done. What kind of chemotherapy is being done? What kind of radiation therapy is being done? I mean, in our part of the world, palliative therapy is just not there, for instance. And that's a huge gap that we have to address as part of this as well. So I think we need to look at the real situation in terms and how then centers could be strengthened. And I think centers should be quite open about sharing that information, because unless we are open about it, we will not be able to address the gaps that exist in our system. And there are many gaps, there's no question about that. The third thing that I would say is that once we've gotten this, and I think what was raised about the cost issue, and that's a major, major issue, is, and I think you touched in your slides as well, is that in our populations, people do not have health insurance, basically. And I can tell you from numbers, in Pakistan, 65% of the total health expenditure, 65% is out of pocket. In India, it's about 70% plus that is out of pocket. In Bangladesh, it's about 80%. In Egypt, it's about 68%. And so if these are the kinds of situations in LMICs, I think it needs to be addressed as how these challenges and how will this be financed, because we don't want to push households into poverty as a result of surgery. I mean, that's the big question for which we need to find an answer. My last point would be then, once we have done this work, and this is what I'm talking of, is about 5 years of really hard work. Or if we work hard, we can do it in 2 or 3 years of time. But then we need to have a strong case with the governments and with the international bodies to see this is what the situation, this is the burden of the disease, this is its expenditure from financing point of view, and what can we do in partnership with the government to start addressing these issues. And that's where I think a lot of evidence and advocacy would be needed. And as the Department of Community Health Sciences, and with my work of health systems for the last 25 years, I think we'll be in a position to work with you, to help you, to assist you, to support you, to be able to push this onto the agenda of not only Pakistan's government, but perhaps the governments that need to be, like the LMIC. So that's what I would think, and that's my few thoughts. I'm going to stop here. I think this was a great session, and thank you for the opportunity. And I look forward to working with you, Inam, and colleagues as we push this whole agenda of brain tumors across our countries and regions. Thank you very much.
Thank you, Samin. I just feel lucky and I'm feel so confident with you at AKU to help me with this. I don't know how I could have done this study. So I'm going to move on to the quick panel discussion. So we're going to make it quick. We have Dr. Tariq Khan, and I will introduce each one of them as I ask them question. And then the panelists have a request, which is Dr. Tariq Khan, Dr. Rakesh Jalali, Dr. James Belugan, Dr. Chen Zongping was sick, so Dr. Wu, Jinsong Wu, has come in, and Dr. Galare Zadeh. So you can always chip in, but I'm going to project one question to each one of you. So Dr. Tariq Khan, you have been one of the key persons in global neurosurgery. When we were doing this conference on global neurosurgery, we went to Harvard looking for some people, and they said, "Why are you here? You go back to your country, and there's Tariq Khan over there." So what? Tariq Khan is already there. So you have done good work, and you have been very active in WFNS. So what do you think about this PASNO working at the global neurosurgery, global neuro-oncology level that should be done?
Thank you, Athar. Hello, everybody. First of all, I must congratulate you, you and your neuro-oncology colleagues, everybody, on establishing this neuro-oncology forum. I think it's going to be a very big help to everybody in the country. You know that we established, the WFNS established the Global Neurosurgery Committee last year. And the initial aims are to make sure that everybody can get craniotomy and hydrocephalus care across the world. And for this, we are reaching out to all the countries and LMICs to see how we can develop their training programs, either in situ in the country or to connect them to some other centers in the world to do that. You know that surgical care was only made part of the universal health coverage 5 years back, that in 2030, everybody must have universal health coverage. We hope that the Global Neurosurgery Committee can show some improvements in care, neurosurgical care, by year 2021, when we present our report to the WFNS committee in Bogota in Colombia. I believe that, launching this neuro-oncology service is going to be a very important step because all the neuro-oncology consultants are going to come onto one forum, and they'll be able to discuss all the important matters, and the treatment would become standardized throughout. Also, this would help in better management of patients. As you know, unfortunately, due to lack of education, patients are coming in very late with very large tumors. So I think public awareness and awareness with the GPs is again the most important step. I believe what you have started already, developing a brain tumor registry and data collection, I think is a very major first step. And I'm glad we are part of that process with you. It will be really very helpful. I must also say regarding the money point, the finance point of view, we are very proud to say that our province has been the first province to have put neuro-oncology into the universal health coverage in this new program with the Prime Minister's Sehat Card, so that every patient can have 1 million rupees for treatment of neuro-oncology. So I think that would go a long step, and I hope that the rest of the country will follow the same. I think that would be very, very beneficial to everybody. That's all I have to say. Thank you very much.
Thank you, Dr. Tariq. I forgot to mention in the beginning that you are the Dean of Northwest School of Medicine in Khyber Pakhtunkhwa, and currently the Dean of Neurosurgery Faculty in CPSP. Next, we have Dr. Rakesh Jalali. Rakesh, you probably have heard this name several times already for the last 2 days. Rakesh has been the key person in organizing the Indian Society of Neuro-Oncology. So Rakesh, what advice can you give us? Because we are so similar in terms of our behavior patterns across the border. So you have been successful in setting up ISNO. What do you advise would you give for setting up PASNO? You're mute, Rakesh. Dr. Rakesh Jalali is, by the way, a senior neuro-oncologist and medical director of at Apollo Proton Cancer Center in Chennai, India. So that's just a short. Okay, go ahead, Rakesh, please.
Can you hear me now?
Yes, we can hear you.
Okay. I'd like to, on the behalf of the Indian Society of Neuro-Oncology and all my colleagues here in India, it gives us particular thrill and delight that the PASNO has been launched with the fervor and enthusiasm that we have witnessed in the past 2 days. Special congratulations to you, Athir, for bringing everything together on the same platform. And as you rightly said, and I remember the video call that we had about a month or 6 weeks ago, and thanks to Gela Razade, who I think has just joined us as well. So, so that was amazing because we share similar kind of history, similar kind of culture. We had this fascinating, very inspiring experiences just that we heard from the patient and their caregivers, and it so resonates exactly the way we have in our country and in our parts of the world as well. So we actually started in a similar fashion in 2008. I have to say, you have actually started in a much more organized manner because you already have the everyone come together on the same platform in a truly multidisciplinary fashion, as the program already indicates, and the lectures that we have had for the past 2 days, also the registries that you have already started. So that is a wonderful, wonderful start. And also right at the beginning, you have the international community right behind you, not from the regional, but also the international community from the STO, the IANO, the Asian Society, and also the World Federation of Neuro-Oncology Societies. So I think you are absolutely on the right path. In fact, we will also learn from each other, from you as well. I don't have any particular advice, but based on our experience, maybe a couple of points which perhaps may be slightly different from us than the other international societies, for example, SNO and IANO. So one or two things are, which already has been mentioned and was very eloquently mentioned by Professor Rosenblum, Dr. Gauss-Malik, and many other speakers, to be truly inclusive, which you have already demonstrated very well. So critical to include the neurosurgical oncologists, but also the basic scientists, the other people, the nurses, the allied sciences, and the pathologists and the radiologists. Two important things which are unique to our culture, which perhaps is slightly different than others, is that we do not have dedicated neuro-oncologists as such. It is critical, therefore, to include the general oncology community, even the general neurosurgeons. we do not have the luxury to have, because of the numbers that we have and the doctor-patient ratios that we are challenged with, to have, for example, a dedicated neuro-oncological surgeon, or for example, an adult neurosurgeon or a pediatric neurosurgeon, although it is getting better and better as we pursue it. I'm sure it's the same in Pakistan as we are witnessing in India. So obviously it is therefore very important for a very successful, sustainable long-term program to be inclusive about anyone who takes care of the brain tumor patients really. And because of the diversity with which the care is imparted and the diversity in which our resources are allocated, therefore, it is very important to reach out at the grass level in different parts of the country to be inclusive of a general neurosurgeon, a general oncologist, absolutely important to include a general pathologist, a general radiologist, a nursing care, different hospitals, different level and tiers of healthcare delivery systems to be very, very inclusive. The other thing is on a very practical and pragmatic note is that once we started the society, the ISNO, we kept a relatively modest fees of a life membership of only 3,500 rupees, even till date. 12 years down the line, still 3,500 rupees. So you get a token collection of 3,500 rupees and you're a life member, which is slightly different than other societies where you have to make an annual membership. So that kind of shows the interest of the senior leadership to be, again, very inclusive. We have a student membership also for only 1,500 rupees. And although there has been a lot of pressure to increase it in the next subsequent years, but then you maintain the databases very well. These days with the digital technology, you have the emails, you have the phone numbers, you have the WhatsApps also these days. So you could connect them extremely well. As was demonstrated earlier today, it was a pleasure to include in the MTTs and telepathology, teleradiology and MTTs, and also identify maybe regional hubs. What we have done in India as well is to we actually concentrated on the pathology hubs to be able to get the simple things, like some of which I will touch on tomorrow's talk, is on how to include an IDH or how to include an ATRX and how to include very fundamental and not so expensive actually markers which will help our brain tumor patients. Eventually that is the future. And sometimes what happens in our countries like us, that we tend to delay it for too long because we have some other obviously much more pressing units, but eventually they do have to be incorporated in our routine clinical practice. So whatever is the low hanging fruit, which is relatively inexpensive, you find champions in different parts of the different universities and different hospitals, as I mentioned, at different tiers, that could be very inclusive. And obviously, as you have rightly done, we do have a fixed time for our annual conference, always last week of March and April, and perhaps yours would be September. And then we changed the theme. As I shared with you last time, we were conscious to have a LMIC/emerging country perspective as well for the guidelines, and we made it very inclusive guidelines which have been published in various forums, and some of them which I've already shared with you on the medulloblastomas, the WHO classification, how to be pragmatic about, and you will hear a little bit about it by Dr. Vani Santosh and a little bit myself tomorrow, but also on other common brain tumors, including germ cell tumors and others. And finally, is also important to be connected with the rest of the world, which obviously you are, and we would be delighted both from the ISNO, it will be an awesome dream, and which will be certainly come to fruition as soon as the pandemic is over, to have an ISNO-PASNO joint meeting, and some of us folks come over to Pakistan, and some of you can come here, and that would be a great friendship and solidarity where borders make no meaning, and it's ultimately the patient and the caregiver, which is the central fulcrum on which our lives revolved professionally. And finally, the funding. I mean, funding is important too. I think one of the speakers did mention about it, and there are various methods and philosophies. We worked very closely with the Brain Tumor Foundation of India, and that was so passionately demonstrated by the Brain Tumor Foundation of Pakistan. But also I must give credit, for example, we learned from the SNOSA, which I was very honored and privileged to be part of for the last 3 years, helping the Sub-Saharan Society of Neuro-Oncology in Sub-Saharan Africa. And they were among the first international societies really, where the advocacy group were very much very intricately entwined right from the beginning. And I'm sure Dr. James Balogun will touch upon it. And that's a great, great start whenever you start a professional society, so-called very scientific, but very closely networked and embedded with the patient and support group systems. And based on the philanthropy, based on the membership drive that you have, and based on industry, we do end up buying a lot of stuff from the industry, whether it's our machines or whether it's our microscopes, and it is absolutely imperative. And we were fortunate in ISNO to create a reasonable corpus where the interest of it goes to at least 3 international fellowships every year if they have an abstract to attend any international meeting related to neuro-oncology. We have 5 training fellowships within the country. They can go to any part of the country, whether it is a neurosurgery training, neuro-oncology, pathology, radiation, and so on and so forth. And also in every national meeting, we have a patient advocacy program, both from the adult and pediatric, and we talk about some theme, whether it is seizures, whether it is employment, whether it is coping up, caregiver stress, burden, patient-reported outcomes, and so on and so forth. So these were some of my preliminary thoughts, and I'm very delighted and honored and humbled that you included me right from the beginning, and I look forward to years and years of friendship and solidarity together.
Okay, same feelings are mutual. Thank you very much. Borders mean nothing to us now. And you rightly mentioned James Balogun, how he managed Dr. James Balogun. He's the president of the Society of Neuro-Oncology Sub-Saharan Africa, and he is the neurosurgeon at this point in University College of Hospital in Ibadan, neurosurgery. He was trained in Canada. So, James, would you help us understand the politics that goes around in the world and how you were able to suppress that and make this group, the Sub-Saharan Society of North Africa?
All right. What a great question. It's a big, big privilege to be here. Sorry, my video is off. It's deliberate because it's raining very heavily here. And
that's okay. We know you're very handsome. We know that. We have your picture already.
All right. So thank you very much. And it's a big, big pleasure to be here. And I do want to congratulate you for this great initiation of this society. It's a big, big deal. And I bring you warm regards from the Society for Neuro-Oncology Sub-Saharan Africa. I think Professor Jalali has said quite a lot of things, and the questions you've thrown up actually very unique and peculiar. It's a pleasure to really see Professor Zadi here, as well as Professor Jalali, because at the start, where we were going to form SNOSA in London, this question you just asked was a very big issue. The politics of having to interact across sub-Saharan Africa with different cultures, different population. We had people with different health systems. But again, I think the first thing is to identify people with a passion, people with a commitment to what you have envisioned. You can go on with everyone at the same time, but what we have done so far in SNOSA is to be able to identify key people in different countries. So when you do that, they will buy into the vision, and then they can expand that vision within the geographical location. So it looks like now SNOSA does have point men, point women in different countries. And so they kind of organize within the countries how to pull in membership into SNOSA. So again, this is again focused on what the needs of each country is, so that that is fully represented on the SNOSA board and at different meetings that we've had. I think the other thing is also to be able to have each individual in each country be able to bring what their educational needs are. We usually does assume that the educational needs are general, but even within a country like mine, which is Nigeria, we do know that the educational needs of the guys in the South, it's a little different from the guys in the North, because again, you have disparities in specialist representations, even in neuro-oncology. So you got to be able to identify those differences and then be able to bring in people based on their educational needs. I think the other thing that's also very, very important is the fact that we should always realize that the LMICs always would put emphasis on infectious disease. Unfortunately, even in terms of cancer, brain cancers is actually just a small population of people. The emphasis are usually on prostate cancer, breast cancer. So the big question is, how do you break through? How do you get this thing to really come to the fore? Interaction actually with societies, bigger societies that really are not focused on neuro-oncology is key, because some of them do have little programs at the time and you could just get in. We were able to get into what is called the African Organization for Research and Training in Cancer just last year. And for the first time in the history of the organization, we were able to have a neuro-onc session. So again, that's going to give you a leverage to be able to collaborate with people and to be able to break down what the national issues are, because some of these bigger organizations have gone through what you were trying to go through. So for me, even though Pakistan is one single country, I'm sure that the diversity and the disparities are there. Different regions, different states would have their own issues to deal with, and just identifying people and moving on with the platform will be great. So thank you very much again.
Thank you very much, James. That brings me to the point that I was going to ask Dr. Chen Zhongping. He's not here because he's sick, but then he has another star neurosurgeon, Dr. Jinsong Gu, over here from Fudan University. So Jinsong, China is a different problem. It's a big country with so many people. How do you manage that? There should be some different sub societies also, or not? That's the question. You're mute, Jinsong.
Thank you, Dr. Asainan. So on behalf of our president of Chinese Society of Neuro-Oncology, Professor Zhongping Chen, I would like to deliver a short message from him. Pakistan is one of the most important countries in Asia and one of the links between Eastern and Western culture exchanges. So Chinese Society of Neuro-Oncology currently has nearly 3,000 members and covering most major cancer centers in China. So we are willing to carry out extensive and in-depth collaboration between Pakistan Society of Neuro-Oncology in the field of basic research, continuous medical education, exchange program, international multi-center clinical trial, etc. So our aim is collaboration, openness, and mutual benefits. So we believe medical science knows no borders. The COVID-19 pandemic has had a great negative impact on the world politics, culture, as well as the academic ecology. It is hoped that the active collaboration of the international medical community, include neuro-oncology, can produce a positive response. So gentlemen, looking back on the history, no virus can stop human civilization from moving forward for good. So let's looking shaping the future. We believe the world will become normal after the disaster. So thank you so much, and congratulations on the success of the academic symposium again. Thank you.
Thank you, Dr. Wu. So finally, we come to my what was the word? My main benefactor. That's Gilare Zadeh. She is the one who actually made PASNO, if I can say that. I had a chat with her 2 years ago, and then emails and this and that, and then she basically made it possible. She showed me the way and made the PASNO be formed. Dr. Zadeh is a professor and chair of neurosurgery at University of Toronto, head of division of neurosurgery at Toronto Western Hospital, and senior scientist at Princess Margaret Research Center. And I'm going to cut down a lot of things, Gilare. I'm just going to, people just know you so much. But I did not know that you were going to be the SNO president next year. I did not know that part. Is that true? Okay. So, well, I mean, with all that research in the background and everything, how did you manage to put it together that Pascal is here today? Tell us about it and enlighten us.
Okay, thank you very much. It's really a pleasure to be part of this group. I want to first congratulate you, Professor Inam, for putting this program together, for persevering, and despite the limitations of COVID, in fact, launching this first Neuro-Oncology Symposium for Pakistan. It's really a major accomplishment, and I see number of names that I recognize, and it's really nice to see everybody in this virtual format. Of course, it doesn't replace meeting everybody in person, and more importantly, I had always, as a young girl, wanted to go to Karachi. I don't know why. I wanted that, and I was telling my mom yesterday, I was looking forward to being there and to having some food and experiencing the local culture. So hopefully in the second or third Neuro-Oncology Symposium in Pakistan. I must have read a book about something to do with Karachi, and I always wanted to visit it. But really, I want to congratulate you. The program is amazing and outstanding, and the fact that you've launched this during the pandemic is really commendable. I think, speaking as the SNO president, one of the goals that we have at Society of Neuro-Oncology is really to do just this, which is to partner with teams and multidisciplinary groups throughout the world to be able to establish the foundation of the society that matches the needs of that society. I think if you look at the Society of Neuro-Oncology, we are the largest group in the globe internationally with multidisciplines, but the flavor and nature of the society is very different from, for example, Sub-Saharan Africa SNO, from India SNO, from Latin America SNO. And I think it's because the region obviously demands different focuses. And what I would like for us to do in SNO is to really be a good partner, be able to understand the needs and provide the support and help that's needed to make the Society of Neuro-Oncology within the region successful. And I think just listening to some of the speakers in the past hour, for example, an area that I think has been the strength of your program is the sharing of experiences of individuals who have gone through living with a brain tumor. And that's something I would say that us as SNO have not really been our focus traditionally, because the nature of our society is different. And it may be that for yourself, taking that approach would actually be very helpful and very impactful, engaging patient advocacy in making sure that the society has momentum, sustainability, and a need. I think every region will have to identify their needs very differently. And I would say to James' point, which is very nice to see you, James. I miss seeing you in person. But when I thought about the Society of Neuro-Oncology for Sub-Saharan Africa, it was really born out of an initial need that was brought to my attention through International Brain Tumor Association and the patient advocacy groups of the Sub-Saharan Africa. And they actually catalyzed the impetus to start the society. And then subsequently, key leaders such as James and others within the Sub-Saharan Africa community really became instrumental in forming the society. And where we were able to help as SNO was to focus the 3 to 4 years of the international scholarship towards making this society a success, allowing the momentum to build and the support to be sustainable. And as I've mentioned to you in our personal communications, Professor Enam, I think SNO could make that commitment to the Pakistani SNO to be able to actually sustain and maintain the momentum that you build this year, to actually then grow the society and give it more formality and structure, and work with you to understand what is the commonality, which is what Rakesh had mentioned. And again, lovely to see you as well, Rakesh. what is the commonality that will bind people within your community of neuro-oncology? And this comment from Rakesh actually stayed with me ever since we met in London to form SNOSA, which is, for example, for India SNO, there was one very simple common goal. Every patient with a brain tumor would require a CT scan. I don't know if you remember this, Rakesh. Obviously, this is something you implemented, but it may seem very minor, but in fact, it will be very binding, and perhaps you can comment on that a bit more as well. But I see ourselves as SNO, as the International Society of Neuro-Oncology, really in a position to support, help, but work with you as best we can to understand where your needs are, and then in turn learn from you areas where your strength lies that can help our society build additional layers and latitude to what we do. And I would say, again, in brief interactions over the last hour, listening to your speakers, the sharing of the experiences of the patient is, for example, something I think we have room to learn from as well.
Thank you, Gilare. I'm older than most of you guys are, but I feel like a child working with you, Rakesh, James, Jin Songbu, and other people. Chas, thank you for leading me, guiding me through Zarni also. So before I pass it on to our dean, I just want to mention one thing, which is my mistake. I wasn't sure that how involved it would be initially. Is we have our dean of nursing school, Dr. Rosina Carmeliani, also in here. And Dr. Rosenblum brought it up that, the most important factor in the Society of Neuro-Oncology is not the doctor, but the nurse. I've been messaging and texting with Dr. Rosina Carmeliani. So Dr. Rosina, do you have a sentence to say? I know we are getting late, and Adil is also waiting to speak, but I just wanted everybody to acknowledge your presence here. Everybody, I want to let everybody know that we have to work with this important part of the medical community, the nursing. Otherwise, we will not be able to go far in taking care of the brain tumor patients.
Thank you, Dr. Inam. I would not take a lot of time, but I would just say thank you so much for inviting. We are part of the same healthcare providers team, and we work together. This was a truly few hours, but amazing journey of learning and a teaching moment for me, especially when I heard the narratives of patient and patient primary caregivers, family and primary spouses. I think we as nurses need to hear these narratives more from the patient and from their family members to improve our nursing care. And I would very much like to be connecting our specialty track nurses in this particular field, and we can take it forward as a team. So thank you for this opportunity. Lovely.
Thank you. So next is our Dean Adil Haider. He is the best thing that has happened to AKU. Adil, I'm not trying to butter you up because I report to you, but honestly, I say that behind your back also. So that's the best thing that has happened to AKU. Adil is a graduate of AKU alumnus, and he spent time in public health, MPH from JHU, and then went to Harvard, and then he decided to come to AKU to fix things up. He is a great speaker, and I'm sure he will wrap everything up into just a beautiful bouquet. Adil, you're on.
Well, thank you so much, Professor Athar Inam. And I want to begin with acknowledging the presence of our president, Mr. Feroz Rasool, our dean of the School of Nursing and Midwifery, Dr. Rosina Carmeliani. It's so great to always be, we're not on a podium together, but on a sort of virtual podium together as usual. The distinguished officials of neuro-oncology societies from around the world. I know so many of you are here. And in particular, I want to make sure to really begin with acknowledging Chairman Emeritus and one of our keynote speakers, Dr. Mark Rosenblum, and Dr. Ross Malik from Michigan. You know, the two of you, decades ago, made a decision. And the decision must have been, and there's probably a lot of discussion, about a young man from Pakistan called Athar Inam. And at some point you decided that he was worthy of your investment, time, and I'm sure a lot of energy. And I'm sure you were very proud that now, years later, you see him not only successfully leading one of the preeminent departments of surgery in Pakistan and this region, but also making something that will, inshallah, last for a long time in the form of PASNO. So congratulations to you. I'm so grateful as a member of AKU that you made that decision to help train Athar years and years ago. And it must be so rewarding for you to see how it's passed on, that now one of Dr. Athar Inam's trainees is, you see him right there, Professor Shahzad Shamim, who is the service line chief running the neurosurgical patient care operation and the neurological, so he's the service chief for mind and brain, so neurology, neurosurgery, and psychiatry, among others. And then he is now training his chief resident, Dr. Saqib Bakshi, as far as I know, is one of the current, he just comes to mind as one of the current chief surgical residents, chief neurosurgical residents, you know, and the line that you create over the years. So I just wanted to start and acknowledge how we as professionals train people and the impact that we can have over so many years. It really is a pleasure to be amongst all of you, of course, during these unprecedented times, during this COVID situation, doing this virtually. And I gotta say, I'm a trauma surgeon, and I've always been in awe of those people who, you know, neurosurgeons who took care of immediate trauma cases, or our neurology colleagues who would help with rehabbing the patients. And the reason why I was always in awe of them is because they're so meticulous in how they plan things and how they help people get back to their functioning. And so I'm not surprised in how, you know, today's events, you know, started with a MRI of a patient. And then really the last few minutes, of course, were about the society, but those two presentations by Ms. Aisha and Ms. Komal Sayed, I mean, weren't they just incredible? And to both of you, I want you to know that, you know, while you think you're helping other patients and other families, I want you to know that you're helping us physicians and nurses and all sorts of care providers more than you could ever imagine. I mean, I was hearing your story and I could just relate to my own family. And, you know, the fact that these stories are repeated hundreds of thousands, you heard Samin Siddiqui and others, hundreds of thousands of times a year, explains why we here in Karachi, it's 8:30 p.m. on a Saturday evening, but it's worth it, right? Why we are here. We're here so that if we can make a dent in the stories that you told us about, Aisha and Komal, if we can just make a better outcome for patients like yours, it's totally worth it being here. Now, the issue at hand is that, you know, CNS tumors are on the rise. I was looking at some data in the Lancet which said that there was a nearly 20% increase over the past 25 years. And so what we're doing here with PASNO is just so important. And when AKU, the Aga Khan University, was formed, it was formed really to create leaders in healthcare. And so along with doing the stuff that we do within the university, I am so grateful that Athar and other colleagues have banded together with people from around the world. And of course, from within Pakistan, most importantly, we see Dr. Tariq Khan and all others, most importantly within Pakistan, to come together to make a difference. And I wanna also acknowledge a few folks that I got to hear, and there are so many great people, but in particular, Chas Haynes, you know, the fact that the World Federation has really come forward to help. Dr. Rakesh Jalali, it is always such a privilege to be on a platform with colleagues from India. When I used to work in the States, I was with them all the time, and some of my best friends are from India. But when I moved to Pakistan, we don't get to do enough together. So it's so great to see us come together. And it's so great that Athar is learning from you, because this is how it's supposed to work, right? And then one of the final talks by Dr. Galari Zada, and how you have come forward to help to say that snow can help and lead the way. I mean, that's just fascinating. That's fantastic. And I know, because I just moved from North America, and so many people there want to help, but then they don't have the best avenues to help. So I hope this is a very fruitful collaboration and avenue where you feel that efforts of SNOW will lead to better impact through PASNO. And I think PASNO has a great future, because it'll band together neurologists, neurosurgeons, radiologists, and oncologists all together. And this is necessary given the complexity of cancer care. I hope PASNO will be able to hold many more collaborative efforts just like this first annual which I think is going to become annual, right? Neuro-Oncology Symposium, and so many other things. And so before I close, I want to again express the more than 1,000 people who have participated. Somebody texted me that there's still 700-800 people online right now. So thank you all so much for being here, being part of this symposium. I know a lot has happened, and this final session was just incredible. And so again, congratulations to Dr. Athar Inam, of course, Dr. Adnan Jabbar, Dr. Shahzad Shamim, Dr. Noreen Mushtaq, and all of the colleagues who worked so hard to put this 3-day event together. And of course, our IT colleagues and others who are now bringing us together in this virtual world. Congratulations to all of you, and I look forward to many more successes through PASNO and all your colleagues. Thank you so much.
Thank you, Adil. With that, I bid you all peace and thank you, and good evening and good day.
Bye, everybody. Hi, Zion. It's nice to see you.
Hello.